to call the meeting of the board to order. Will the secretary please call the roll?
Director Curry,
Present.
Vice Chair Deere,
Deere is here.
Director Garza,
Present.
Director Guggenheim. Director Guggenheim, you're muted. I will circle back to her. Director Harrington,
Present.
Director Kim, Director Kim, Director Ketting,
Present.
Director Munar, Director Munar, Director Prendergast,
Present.
Director Ryder,
Here.
Director Story,
Present.
and Chair Taylor.
Present.
Circling back to Mary Guggenheim, we do see you. Can you hear us?
Yes, present. Sorry.
Excellent. Thank you very much. And Director Kim, are you present? And Director Munar, are you present? You have a quorum.
Thank you. Pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. To streamline the process, we'll combine the action items into a combined motion. Meetings of the CCH board and its committees will be held remotely until otherwise noticed due to the determination that a public health emergency exists. The next regular meeting of the board will be held on Friday, October 28th at 9 a.m. The first item on today's agenda is employee recognition, which will be reviewed by Ms. Valerie Amos.
Good morning,
Amos?
everyone. Good morning, everyone. This is Valerie Amos, Chief Human Resources Officer. I have the pleasure of sharing our employee recognition and announcements. So the first one, happy birthday, County Care. 10 years of providing coverage. October 26th is the 10th anniversary of County Care. The health plan was established through collaboration with the federal, state, and county governments to expand Medicaid to low-income adults in Cook County 1 year prior to the ACA implementation date for statewide expansion. Over the past decade, County Care has served 938,000 members, facilitated more than 32 million medical claims and 75 million prescriptions, covered 781,000 well child visits and births of nearly 43,000 babies. So please join me in congratulating and saying happy birthday to County Care. Awesome. All right, thank you. Cook County Health residency programs are also being recognized. Cook County Health's emergency medicine and preventive medicine residency programs were recognized in Becker's Hospital Review for being among the best clinical training programs, according to Doximity's 2022-23 Residency Navigator. Physicians contribute nominations, ratings, and reviews. Ratings comprise 3 major parts: current resident and recent alumni satisfaction data, reputation data, and objective data. So please join me in congratulating Cook County Health residency programs. All right. Okay, so the next one is our Emergency Leader Award. Dr. Michael Alabek, co-director of medical student programs and attending physician in the Division of Hospital Medicine, has been named an emerging leader by the Health and Medicine Policy Research Group. In his nomination, Dr. Alabek was recognized as a dedicated problem solver. He takes on whatever obstacle may interfere with patients getting what they need and works for solutions with an eye towards access and equity. He is about making things better for everyone. Despite being early in his career, Dr. Alabek's leadership has already made a tremendous impact at Cook County Health. The award will be given at HM PRG's gala on September, it was already done yesterday, obviously. So please congratulate Dr. Ellebeck. I'm not certain if he's here today. If you are, please join us by camera. Dr. Ellebeck, if you are on, congratulations.
Well done, well done. Congratulations.
All right. The next one, fellowships in advancing health equity. Dr. Dara Amin, Director of Quality Improvement and Patient Safety and attending physician in the Department of Emergency Medicine, has recently been named as a fellow in the 2 prestigious healthcare programs. Dr. Amin was named a fellow in medical justice and advocacy by the American Medical Association and Satcher Health Leadership Institute. Founded on the principles of servant leadership, justice, and collaboration, fellows in this program will generate and exchange solutions and implement health equity projects that inform policy to ensure optimal health for all. She was named a fellow in diagnostic excellence by the Society to Improve Diagnosis in Medicine, SIDM. During the course of her fellowship, she will be focused on better incorporating patients with limited English proficiency in the diagnostic process by enhancing emergency room discharge practices. That's a mouthful, and congratulations, Dr. Amin.
Congratulations.
If you are on, please share yourself on the camera. All right, next one. We are also pleased to welcome some new hires. Our service line business director, Mazin Abu Ghazala, our manager of complex care coordination, Lamont Boswell, our nurse services business operations manager, Priscilla Carroll, our physical therapy manager, Brian Irvin. Next slide. In addition to that, Dr. Eric Makaitis, our chief quality officer. And we have also some administrative support in the C-suite, Ms. Angela Sims Haynes, as well as our Senior Director of Physician Revenue Cycle, Horatio Tucker, as well as our Vaccination Site Supply and Distribution Manager, Albert Tyler. Next slide. Craig Williams, who's our Interim Chief Administrative Officer of Operations and Development, as well as our Medical Staff Credentialing Manager, Diana Ulici, and Cynthia Washington, our Director of Pre-Patient Access. Next slide, please. We have some rehires, some rebound folks, and we're excited about that. Chief Psychologist of ACHN, Dr. Rocco Domenico, as well as Delegation and Vendor Oversight Management of Health Plan Services, Ariana Relaford. Next slide, please. We are excited to officially share our promotions. Angelo Banyan is our Chief Information Officer. We have Carmelita Caranal as our Divisional Nursing Director, Monique Crawford as our Clinical Case Manager, Mohit George as our Clinical Case Manager as well. Next slide, please. Kate Hetland, our Senior Communications Manager. We have Dr. Manhal Khalif, Chair of Division of Neonatology. We have our Clinical Case Manager, Moheen Matthew. Marisol Nunez is our Manager of Ambulatory System Operations. Next slide, please. And finally, we have Maritza Pandoja, our Pulmonary Clinical Director, and of course, Dr. Arnold Turner, who has been promoted to the Chief Hospital Executive position at Provident. Next slide, please. So please congratulate, join me in congratulating all of the new hires, the rehires, and promotions, and I will turn it over to Ileana Mora. Thank you.
Thank you. Congratulations and welcome.
Actually, Ms. Amos, this is Debbie. I think that the next section of the agenda is for the public testimony. The Ileana part of the presentation happens later in the meeting in the CEO report.
Correct.
Sounds good. Okay, thank you.
Correct. As our secretary highlighted, the next item is public testimony. Madam Secretary, do we have any speakers who registered to provide oral testimony?
We did not receive any registrations or testimony submitted.
Thank you. And as a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted to the website. Following receiving any oral testimony, the secretary can read the list of names of those who submitted written testimony into the record. Do we have any list of names that we should read into the record who submitted written testimony?
No, we did not receive any.
All right, thank you. The next on the agenda are the board and committee reports. The minutes of the August 26th board meeting are being presented for your approval. Approval will take place in the combined motion later in the meeting. Are there any corrections or revisions needed to be made to the minutes? Hearing none. Next, Director Prendergast and Valerie Amos, Chief Human Resources Officer, will review the HR metrics. The committee did not meet this month, so those metrics are being presented directly to the board. Director Prendergast.
Okay, thank you so much, Chair Taylor. Good morning, everyone. The Human Resources Committee did not meet this month. Their next regular meeting is scheduled to be held on Friday, November 11th, 2022 at 12 noon. The committee is due to present metrics, and so I'll turn it over to Ms. Valerie Amos, our Chief Human Resource Officer, who will review the metrics today. No motion is needed. The metrics are being presented for informational purposes. Thank you. Ms. Amos.
Thank you again. Good morning again, Valerie Amos. So our first slide before you is an update on our hiring metrics. So we have received over 2,500 requests to hires or vacant positions within the HR team. That is what our team is working on. We have increased our number of hires to 510, and I realized I had a typo after I sent this. My apologies. Should be 296 external and 214 internal. Those are the people who have started or transferred or who have been promoted. So we're always excited about our transfers, upward mobility in terms of promotions. I will also share some updates on our job fairs because that actually changes the numbers. And hopefully we'll see that update in the next board report, but we already do have preliminary numbers for that. So we are progressing in the right direction. We are still working on some backlogs, and we have additional resources to help us with that, as I will share in upcoming slides. Next slide, please. In terms of the activity, as I mentioned before, there are about 2,500 positions that our team is working on. As you can see, the hiring funnel and the breakdown, I won't go through everything. There is some progress. We posted over 2,100 positions, so about 83% of those had been posted already. We still have some to post. And then the posting closes, and of course, there's verification and validation processes and interviews, and the managers have completed about a third of those interviews, and we have 20% of those that result in vacancies filled. So the number of hires is that 510 number. That number of candidate offers, which is 28% versus the filled vacancies, we have metrics in place to really capture what's happening between those two numbers. I've mentioned some of that in previous meetings. We have our internal dashboard, and we're looking at candidates who may have declined our offer, the reason why. We are also looking at, again, HR optimization to enhance and improve our processes to ensure that we don't lose candidates. So that is a constant journey for us. Next slide, please. In terms of the activity, year by year, I thought that this was extremely, notable. We are tracking and trending quarter by quarter the number of hires. And so FY22 is up top. It's in the salmon color. And so we have made some strides with hiring, as mentioned before. We are still looking at average monthly hires per quarter, per year as well. So we're still trending slightly below last year's in terms of the average monthly hires, but we know the first quarter of last year was in onboarding of, I think, some support workers within CCDPH. So it wasn't the traditional process, but we are definitely making some improvements and movements with our hires on a monthly basis. The internal versus external breakdown is also listed below for you as well. Next slide, please. This is our separation activity. Here's where we still have to work and work very hard. We have to work hard on retention, and we have a number of measures in place, a number of great things in place, partnering with our Chief Experience Officer and our CEO and other colleagues, definitely moving in the right direction. But as you can see, there is still quite a number of individuals who are exiting the organization for a variety of reasons. Our system captures the resignations, retirements versus discharges. So the number of resignations and retirements continue to lead the high numbers. We have a ton of tenured employees here, which is great. That shows their commitment and loyalty to the organization. But we have to invest in ensuring that we bring new recruits in and focus on those individuals and really building the team back up with some additional talent, as we know that this is a constant turnover as it relates to retirement of individuals who have been at the organization for several years. Next slide, please. This metrics is really the turnover. We just want to depict quarterly turnover. Now, again, our numbers are great in terms of benchmark standards, but I often go back to FY20 when I wasn't here, and I noticed, again, there's more than 6,000 employees as the base, and now we're at 5,500. And so even though the turnover number is very modest, which is great, we still have to look at that base and ensure that we are bringing that talent in, attracting the right talent to the organization with sustainability and retention. Next slide, please. So again, this is the slide that you see at every board meeting, and I won't stop showing this slide because here are the 4 fundamentals or focal points. We have made some significant progress with recruiting talent within the HR space. We have hired permanent recruiters as well as brought on additional contract support so that we can really reduce the number of job openings per recruiter so that we can be more efficient. In addition to that, we've been implementing, of course, recruiting strategies and activities, and that has had an impact on our time to hire. We're still working with our HIS team, with our Chief Information Officer, Angelo Banyan, as well as partnering with the ERP team at the county, Jill and Tom and others at BOT. So we're very appreciative of partnerships as we look to improve our technology solutions as it relates to recruiting. There are a lot of great things on the landscape. We have a plan in place, and we have been working closely with HIS as well as BOT. As I mentioned before, retention, we want to understand what drives our employees, and I'll share a little bit about some listening sessions that we think may be critical for our employees, as well as a little bit more about press gaining. Next slide, please. As you know, you have been so supportive in allowing us to bring additional supports in. First 100 days, there was an assessment completed. I conducted a SWOT analysis, realized that we need a lot of support. And so you've answered that request, and we have several vendors who are here with us working on different arms of the project. Slalom is our project management arm, and they have been with us now for about 7 months. They've been supporting us on program management, process optimization. So what does that really mean? That means streamlining, eliminating waste, documenting standard operating procedures, things that we haven't had before, assisting us with training materials, ensuring that We are training folks to be compliant as it relates to hiring. The technology solutions, really working and advancing our programs and processes as it relates to technology, identifying and assessing which technology solutions are working in our favor and which ones really need some support. In addition to that, we've been hosting, vendor status calls on a daily basis. We have the recruiters on these calls. We're checking, tracking and trending our supports and our outcomes on a daily basis. In addition to Slalom, Cross Country onboarded in March, and they have actually the 500 plus vacancy is probably close to about 700 now, but they've been really operating to support us there. So they have recruiters with us. Some of those recruiters have been on site, of course, for training. They assist us with job fair coordination, and then they also work virtually. So it's been a huge help to have their bodies with us. Incredible Health is a talent sourcing support tool. It's really, it's a system. And so we started to partner with Incredible Health in June, and we're going to continue to assess that partnership and relationship. But their goal was to identify nursing candidates for us. We wanted to have levers in place, a company that we understood was well versed in identifying nursing talent to attract to Cook County Health. Brazen is a virtual hiring platform. It's not people, it's a platform. So it's technology solutions, and I'll share a little bit more about that as I have before, but we hosted our 6 job hiring fairs through Brazen. Deloitte just started with us, so we're excited to have them with us. They are working on 2 arms of the project. They have boots on the ground with us, so some recruiters. In addition to that, their second arm of their support is HR optimization. So they also have project management team members who are working on our back-end solutions, our employee-based programs. What are we doing in terms of performance management? We look to really launch a system-wide performance management tool. We have something, but it's not officially launched, digitized. It's not in place yet. So we want Deloitte's help and support with that, as well as some of our workforce development, so training programs and ensuring that we have the right safeguards in place to keep our employees satisfied with their career growth, their paths, and so forth. So Slalom is really here to support us on the front end with all of the recruiting matters. Cross Country has boots on the ground with recruiters, and Deloitte has the mix. They have both HR optimization for back-end processes as well as recruiters. Next slide, please. You've asked me, what have these partners done for us? So I took the liberty of putting together just some quick key performance indicators. This is not the end all and be all, but we are showing some improvements with our recruiting efficiency and having an impact on hiring. So as I mentioned before, those vendors, we have now 14 recruiting resources. Some of them are still in training, but to have 14 additional support people is phenomenal for us because of the backlog that we have inherited over the past, couple of years. The number of vacant jobs per recruiter, as I mentioned, has also decreased. So we're excited about that because if the recruiters have bandwidth, then they can focus on engaging the candidate, engaging the manager, ensuring that there is a much more rich experience for both candidate as well as manager. Today, we are moving fast, and so sometimes those things, are diminished. So we want to provide that level of service and support that is needed within the space. So we want to continue to drive that number down to a more meaningful number towards the benchmark standard of 50 to 60 jobs per recruiter. So we're on our way. Optimizing, again, HR operations. We've decreased the hiring cycle. We still are not at benchmark. We still are not under the 90 days. We still exceed the 90 days, but we are well on our way of driving this down. We've also improved productivity with the recruiters. So some of our optimizations, and I didn't go through every one of those, But as I mentioned before, we have been working with Slalom, and now we are working with Deloitte. But most importantly, the recruiter time savings is critical. If they have more time, they can extend more offers. They can also, again, engage in more meaningful conversations with candidates so that they are attracted to this organization. So we're working on driving out some of the administrative baggage that the recruiters are working with to identify what those pain points are and really assess and address them appropriately. Accelerating hiring, I mentioned Incredible Health. So Incredible Health has identified about 90 nurses that expressed an interest in Cook County Health. And so collaborating with Dr. Bina Peters and her leadership team, we have a systematic way of having those nurses' resumes reviewed on a weekly basis. Those resumes are shared with the management team, and they are conducting interviews on a weekly basis. We're seeing a decreased time in terms of processing these candidates, and now we'd like to convert more candidates into hires. Mr. Harrington?
Yes, I have a question. There are 90 nurses sourced. How many of those nurses were actually hired? I mean, is there a relationship between, is 90 sourced, 90 hired, or 90 sourced
No.
and 10 hired?
No.
Or
Yes. So we are in the early stages of this. Even though we partnered in June, it took a little bit to get them off of the ground. So we have been working with nursing, and they have identified, I want to say, 8 hires. 2 of them have accepted the offer at this point, and we're continuing to determine if all 90 candidates are really interested in Cook County Health and the shifts and so forth. Because as the nursing team interviewed some of those candidates, they realized that they weren't quite as aligned with our organization. So we're working on creating a stronger relationship and a realistic job preview with Incredible Health so that these candidates know which roles they're interested in, what we have to offer. So we're still building that out, but great question. Director Curry?
All right, thank you. I just wanted to piggyback on Director Harrington because that was then a little misleading for me because it says the key performance indicator is hiring, and this is actually a process that you're looking at improving that will result in some hiring. So if there's any way to, present that a little differently to make sure, because I zeroed in on the hiring part, which was fantastic. If you don't mind, thank you.
Not a problem. Thank you. I wanted to present some early numbers in terms of sourcing, but actually we are focused on those hiring numbers as well. We just hadn't gotten through them all. So I appreciate that. Thank you. In terms of virtual job fairs and expanding the marketing, we hosted 6 job fairs in the month of August. So I believe that this is the first time that the organization has ever done anything like this. And so we hosted them virtually. And we did fill 52 jobs. So those are real hires that accepted our offers. We had more offers than folks accepted, but most importantly, I will expand on that in the next couple of slides. Next slide, please. Impact. So this slide is important because I wanted to showcase, for the first time since I've been here and prior to me actually starting, we were looking at some historical data. Our separations fell for the first time to the lowest rates in 19 months. New hires actually outpaced the number of separations. And then again, we are definitely trying to make an impact on the overall head count. We know that we can run hard. We can definitely start attracting talent with our signing bonuses, which were recently approved, and we applied those signing bonuses at our job fairs. However, we still need to look at the number of separations. So it's just this creates momentum. We're excited about it. We will continue to look at that trend. So the first time in several months, we're just seeing a little bit of movement there. Just wanted to pause and share that. Next slide, please. As I mentioned before, we hosted those 6 job fairs. We thought we utilized our platform, Brazen, which is the virtual recruiting tool. We certainly did this in record fashion. We move quickly when we need to move quickly. And so we had about a month's lead time so that we can promote it. You probably saw some of the job fair flyers, but most importantly, we partnered with Cross Country, which brought our recruiters in, the contract recruiters. They also have a marketing arm, and we are partnering with them for their marketing arm. So they created TikTok videos, they created social email blasts. They also, created a branding campaign in partnership with our internal communications and marketing team under Karen Stanzik and Alex Normington. So this was in conjunction with our team. They created a nice, communication strategy for us to really attract those candidates nationwide, not just in the Chicagoland area. So we were very blessed to have them. We will continue to build on that platform. We are working with Cross Country, Res Publica, and our internal marketing and communications team to also build out our careers website. So that's going to be helpful too. And hopefully we can share some new images with you in the upcoming board meetings. So just to refocus, we hosted 6 job fairs in the month of August. Why were these chosen? These were areas that said, hey, we want to raise our hand and definitely get on the agenda for job fairs. And then others, we just knew that it was a need because of their vacancy rate. So social workers, nursing, pharmacy, medical assistants, as well as CERMAC staff members, which included medical, social workers, mental health specialists, as well as nursing positions, clinical nurses, as well as licensed practical nurses. And then, of course, the radiology team, which also hosted about 4 different jobs. So as a summary, Director Curry, just to get down to the chase, we had a lot of folks who were interested. Cross Country did a phenomenal job of promoting this. Brazen did a phenomenal job of allowing people to register for the event. So this was not Taleo or applications in our system within HR. We overlaid this platform for these particular events. So we had over 640 people who started the registration, and then there was a drop off because there are pre-screening questions. We want to ensure that people understand what the job entails. We also want them to understand the shifts and the locations so that they have an opportunity to review it and sign up for an event that makes sense. We also provided details for them to go into our Taleo application and apply. So of the 391 who completed the registration, we had a very notable number of attendees. These were all virtual. So we had over 330 folks who attended, and 178 of those resulted in interviews that were completed. Why all of the others were not? Again, we look for the qualified individuals. We have to maintain compliance with our standards in terms of minimum qualifications. And so a number of individuals just did not meet those minimum qualifications. The teams were really excited and provided a number of offers, 71. And as of the 14th, 52 individuals have received contingent offers. So what's so different about this is we were able to extend those offers while they were virtually with us. Our goal is to, again, expeditiously extend those offers, accelerate hiring. That's our goal. And so in our effort to do this, a full disclosure, you're going to hear the EPO report, and she's going to share some concerns. And that's notable because we pulled this together, 6 job fairs within a month. And so there was a lot of training, a lot of documents, a lot of leadership individuals for the first time participating in job fairs. So it was not perfect, but most importantly, given the fact that we have quite a number of vacancies at this organization, we're committed to ensuring that there's there's unbiased hiring. Every candidate who is minimally qualified for the job, we're committing to ensure that those individuals are selected for interviews at these job fairs. And so doing that, we ran very fast. So we will certainly continue to partner and work with our EPO office to remove any obstacles, ensure that there's speedy hiring, that the process remains fair and equitable, because again, we were successful in completing 6 job fairs in 1 month at Cook County Health, which is the first in the history, as I understand, with the organization. So lessons learned. We will go back to the drawing board. We are definitely looking at our lapses in process. We're going to minimize and eliminate any issues in the future, but most importantly, we did it. So I congratulate my team. I certainly am excited to share that the leadership teams within the organization were very, I think they were really excited and they were great partners in this process, but there are lessons learned. And so we are humbled and we will learn those lessons and we will improve and we'll continue to do what we need to do to advance hiring here at Cook County Health. Our patients deserve it. Dr. Prendergast.
Yes, I just want to kind of echo some of your congratulations to your team, but extend it from me to you and your entire team. I think this is just incredible. I know that everyone, we're all aware of the fact that we're in this very trying time for, not only as we kind of with the pandemic, but, in midst of the great resignation, as it's been named, and just to be just a few percentage points from where we were in previous years I think is just a real testament to the work and the dedication and the innovation that you and your team have brought to this process. It looks like based on the contingent offers made and accepted, it's almost a 3 out of 4. So that's just really incredible. And I think that is, yes, always there, there be things to modify, but I just want to commend you for just thinking outside of the box, bringing some innovation to this, because, we can have the best programs, but our true talent, our assets are our employees, right? So everything won't work without that. So I commend you and your team for keeping your eye on the true prize, understanding that we need, our asset is our people. So thank you.
Oh, thank you. That's really appreciated. It was definitely a team effort. I mean, our communications department is also so fantastic. They promoted, and again, all of our vendors, the support from Slalom and Cross Country, and I mean, it's just amazing. We're starting to feel like we are making a difference. The stats are the stats, but the tremendous work behind it, sometimes that's not as visible on these slides. So I truly appreciate that level of support. Thank you. Director Harrington? You're on mute.
Yeah, several questions. One goes back to some earlier slides, and as I look at this slide, and I thought about this, for the posted positions and the separations, is there a specific class that outnumbers the positions we're looking for, as opposed to we're looking for a lot of people? Is there one class of position where there's a significant number that we're looking for? I'm assuming I know what it is, but I just want to make sure that I'm correct.
Well, if you guess nursing is our largest number of employees, 1,300.
Okay.
Of course, they have the largest number of vacancies because, of their reach. And that's why I think we partner with nursing, so much in the past. As you probably recall, we hosted nursing events a month after I started. So that was July of 21. Then we had another nursing job fair in October of 21. Then we had another one in April of 22. And then we just had one in August. And then we have more nursing job fairs as well as other departments planned in the next few months, because we want to give everyone an opportunity. So we'll be looking at the labs again. We'll be looking at, police officers. We have plans for physician assistants, and of course, more nursing departments. So there are just so many areas within the organization that we need to touch, and we want to try to, really balance that out. It's really tough, but I think that people understand the momentum that we have, and we just want to advance that as much as we can.
Okay, thank you. And the 52 contingent offers, that's part of information was in the earlier slide?
So
in terms
no,
of-
actually, no, that's what I wanted to share. Remember I said we had 510 people who joined. So those metrics were at the end of August. So when I produced that first slide, those are actual people who have started. These are folks who attended the job fairs in August. They accepted the offers, but they had not started by August 31st, of course, because our last job fair was August 31st. So next board meeting, you're going to see these offers of hopefully people started, you know, in their positions, because I'm always like a month, the month prior is what I report out at this meeting, but I wanted to give you a sneak preview into what next board meeting should look like.
That's helpful. And lastly, you say our search is national. Do we offer people that come from out of town any assistance with relocation?
No, we don't have that service, but we certainly have the signing bonuses that were recently approved by the Board of Commissioners. We are attracting more talent, I believe, based on that. But no, not at this time. There's no relocation.
Thank you.
Mhm. Thank you. Next slide, please. All right. Any additional questions? Thank you, everyone. Have a good day.
All right. Thank you, Ms. Amos. I'll go ahead and turn it back. That concludes the report for the HR committee. I'll turn it back over to you, Chair Taylor. Thank you.
Thank you very much, Director Pendergrass and Ms. Amos, for the very thorough report. Next, Erin Deline, our Chief Administrative Officer of Health Plan Services, will review the Managed Care Committee metrics. The committee did not meet this month, so these metrics are being presented directly to the board. No action will be required. The next meeting of the Managed Care Committee will be on October 24th at 10:30 a.m. Mr. Galena?
Thank you, Chair, and good morning, Directors. Aaron Galena, Chief Administrative Officer with Health Plan Services. Starting off with our membership numbers, total membership through September is at 432, almost 433,000. On the next slide, you see our overall market share data. This is through July, based on the latest data that the state has published. We're continuing to increase in terms of market share at 32.7%, and we expect as we get some more recent data that we'll be approaching the 33% mark. The next slide shows our growth compared to the overall Cook County managed Medicaid market. Over the past 12 months, we've increased about 7% in terms of enrollment versus the overall market, which is up about 4%. You will note here that there's a decline both in our membership and in the overall Cook County Medicaid market, and this is mostly due to a one-time catch up that the state did on processing terminations for members that had some other type of coverage. So we saw a one-time impact for that, and our most recent numbers, as we're looking forward, show a return to the typical growth pattern that we've seen for the past couple years. The next slide shows our membership compared to budget. As you know, we're continuing to exceed the budget due to the state's pause and redetermination. We expect the next potential end date of the public health emergency would be sometime in mid-January. So we'll continue to monitor that. We expect we would know by the middle of November, which would be the 60-day notice period that CMS is committed to if the PHE will be ending in January. The next slide shows our operations metrics, which are all performing within SLAs, so no concerns here. And then our next slide shows our inpatient admissions per 1,000. Red bars are prior period, blue bars are current period. So we're seeing lower inpatient utilization per 1,000, which is a positive trend. The light blue bars here are projections that we have going forward based on our authorization data and actuarial analysis for claims that we haven't yet received. So we are seeing a little bit of an uptick in the most recent months in terms of that inpatient utilization. So we're keeping an eye on that, but that's mostly driven by projections at this point. So as we get that actual experience in with claims, we'll have a better view of that. The next slide shows our COVID vaccination rates. We've broken this down by age category and by number of doses. So the fully vaccinated column here, we're defining as members that have received at least their first 2 doses of vaccine or the single dose of the Johnson & Johnson. You'll notice there's significant variance by age category. So highest vaccination rates, not surprisingly, in the older populations, and lower vaccination rates, particularly in children under the age of 12. The next slide shows our claims payment turnaround times. We've been continuing to be right at the 30-day mark. And our final slide shows the claims payment turnaround times by aging category. If you want to go forward one slide, Doug. And you can see that continued trend of the decreasing claims outstanding, particularly in the 30 to 60 day category.
Mr. Later, I think we have a question from Director Harrington.
Yeah, my question was relative to the slide about vaccinations. And I couldn't tell if that last column included the new shot that's over it, because it said 3rd shot and booster. And so are they combined, or is that's what I couldn't get from the slide?
Yeah, we haven't broken that out currently, so it's just any booster or 3rd shot. So we haven't differentiated on that slide yet between the most recent bivalent booster versus previous boosters.
And fully vaccinated is 2 shots then, right?
Correct.
Okay. Thank you.
Any additional?
Director Ketting, did you have a question?
Yeah, I have a follow-up on vaccination. Do we have any thoughts about a campaign to improve the booster rate? I think that we're going to need to think about this, because my very unscientific read of the data is that this is going to have to become an ongoing campaign, kind of like flu shots each year. And so I wonder if we have thought about standing up campaigns, or if we're going to, and how we're going to approach that over time.
Yeah, so certainly we've continued outreach efforts to the populations to try to continue to emphasize the importance of vaccinations. And to your point, we're beginning to evaluate how we build that to be a little bit more of an ongoing program than sort of the initial one-time push that we had. And in particular, thinking about that in conjunction with the flu shot as well. And so we do also have member incentives that we've now put in place for both of those items, which we hope will help. But we'll continue to do specific outreach campaigns throughout the year targeted at our members who haven't gotten a booster yet.
Yeah, one of the problems I think is this. Go ahead, Mike.
No, go on.
No, I think there's some confusion. I mean, I'm confused too, because once you get 2 shots, you're fully vaccinated. Then you needed a booster, and now there's a new booster. But there's also this discussion about people needing to have an annual shot for COVID, similar to having an annual shot for influenza. And I think that I'm trying to figure out, what does it mean to be fully vaccinated now? because I was fully vaccinated. Then I got a booster, so I thought I was fully vaccinated. Now I have to have a booster every year or a new shot. So some of that language may be confusing the lay public, because I know it's confusing to me. And so I can appreciate the conundrum you're in, but it may mean that we really need to take a look at our messaging moving forward about what people need to do. Because there's talk about this being a seasonal shot. Just like influenza, when you get your influenza shot, you'll probably need to get a COVID shot.
Dr. Hasbrook looked like he has his hand raised. Dr. Hasbrook, you had a comment?
Hi, sure. Yeah, I don't want to take up too much time, but I just wanted to clarify and speak to the issue, because it has been confusing going forward. So we're not quite yet at a seasonal shot for COVID, although I think that's probably where we're headed. COVID has not really presented necessarily as a seasonal pattern yet, much like the flu. So eventually we will probably get on that type of schedule. In the interim, fully vaccinated means you got the whole series and the boosters required at that point in time. Now, the goal line keeps moving, as to your point. And so at this point, it really is about fully vaccinated. Is for all intents and purposes, you got the series and you're up to date on your boosters. This new customized boosters for Omicron is kind of the new thing. And so currently, I don't believe we're saying that you have to have that to be fully vaccinated, because we're going to estimate that there's going to be additional customized boosters going forward. And so that your point is well taken, is that we do have to get a message. But I think right now we're looking at fully boosted. You finish the series, you got the 2 boosters, I guess, if you're over 50, and now there's a brand new booster. And so now we have to start messaging about that brand new booster, because we're coming up to a whole year now. And I do believe we're going to move to probably a annual shot, much like we folded in the last pandemic, H1N1, into the annual flu shot. So we may be heading there. The science isn't there yet.
Thank you.
You're welcome.
Director Kennedy, you have another question, or is your hand still raised?
Yeah, I do. Well, first a comment, then a question, or maybe a second comment. And the general comment is that, I've solved the booster problem. By any time they offer a shot, I get it. I don't want, but that as a health insurance entity, we have both the responsibility and the opportunity of actually helping people achieve health, not just reacting when they get sick. And anybody we can keep out of the hospital or keep from getting really sick is a good thing. And so we need to keep focused on that. And I appreciate the thought about trying to make this an ongoing campaign and incorporating it into our overall plan of operation going forth. Kind of related to that, moving my sort of second point, there was to me a very disturbing article, an op-ed piece in the Trib this week about obesity in children.
Just generally say that.
Pardon?
That's the beginning of a lot of sentences. There was a disturbing op-ed in.
Yeah. You're absolutely right. It could go many ways. But I was particularly talking about obesity in kids and a very substantial increase in type 2 diabetes among children. The numbers are still stall, even though they have a 300% increase. It was against a small base. But still, all you have to do is look in the streets and you see this is a concern. And at some point, I would really like to hear a report from County Care about how it's thinking about obesity in general and particularly among children, because these are tomorrow's problems. And when we start seeing as many kids overweight as we're seeing now, I really see a boatload of problems just down the road.
Yeah, thank you, Director Cutting. Happy to bring back some data and information around that. And I think it's It's a timely conversation because we're in the middle of evaluating responses to our food nutrition RFP that we recently put out. So I think it'll be great context for what's likely to be a contract that we'll be bringing back to the board.
Good, thanks.
Yep, one, and I see Director Curry has, I just want to offer up a resource quickly. When I had the opportunity to work with the City Health Department, I worked very closely with the Consortium to Lower Obesity in Chicago Children, based out of Northwestern, which still exists. So if you haven't, or someone hasn't been engaged or in contact with them, that would be a huge resource locally.
Yeah, I'm going back a step. Thank you for the discussion around the messaging, which I think is critically important. But I wanted to clear something up in my own mind. I may be the only one that gets it though. So there still is what I consider a substantial number of individuals who haven't even got the first dose yet. In other words, aren't anywhere near fully vaccinated yet, haven't gotten the first. And with a lot of this messaging that's going on around a new bivariant, people may assume that they can skip and move to the other. I know there's a process. How do we address that in terms of still as a priority, getting people to start with the first series before jumping over to the bivariant? It just looks like there's so much more emphasis now in the messaging and communication about the Omicron and not the other. But if I understand correctly, you still have to start with the initial vaccine series, moving to boosters and up to Omicron. Is that correct?
Correct. You're not eligible. This is Lamar. You're not eligible for the bivalent until you've had the initial series. Now the other boosters in between, that's kind of the gray area, but you had to have at least had the series, the 1 shot or the 2 shots, Pfizer and Moderna, to be eligible for that one.
So a person who is just beginning to engage, we're talking about several months before they would get to the point. Is that correct? Is that still kind of the glide path?
Yeah, that's correct. First shot, 30 days, second shot, and then probably 2 weeks to 30 days for the booster, and then another 2 weeks before you actually have the immunity from the series. It takes about 2 weeks after you've gotten the last shot, however you define it.
So I think that is part of the point of making that in the messaging, that people should understand that it could take them several months to get from the beginning to catch up where we are now as we're getting into the series now here in the fall. Thank you for the clarification.
That's correct. Yep.
So directors, I think you're seeing the overlap here in county care and the messaging there, as well as our broader public health messaging, right? That you see Dr. Hassel highlighting. And I think the importance of us being coordinated there, which Mr. Gleaner and Dr. Hasbrook recognize, sure. Mr. Gleaner, any additional information? Thoughts?
No additional comments from me. Thank you.
All right, thank you very much. Next, Director Guggenheim will review the Quality and Patient Safety Committee meeting minutes. Director Guggenheim.
Yes, good morning, everybody. The Quality and Patient Safety Committee met on Friday, the 23rd of September, 10:30 a.m. The next meeting will take place on October the 21st, also at 10:30 a.m. So we were very pleased to welcome the new Chief Quality Officer, Dr. Eric Miklaitis, who's with us today, I believe. But I'd also like to pause and congratulate Leslie Frayne, who's been doing a splendid job in the interim time when we haven't had a Chief Quality Officer in place. So thank you, Leslie, for all your hard work. The committee received the following reports, which are included in the minutes: the HRO dashboard, which I think, are we going to review that or not, Madam Secretary?
We were not planning on doing so.
Okay, so we heard about the 30-day readmission rate, the case mix index for medical and surgical DRGs, the top box score, and the diabetes HEDIS measures. We also received regulatory and accreditation update, which is included in the minutes. We had an update on the high reliability organization Dyad on patient experience, that's also included in the minutes. And the presentation was made by Lynn Dang, Chief Experience Officer, Dr. John O'Brien, and Jacqueline Witten, who's Chief Nursing Officer at Stroger. The presentation included the patient experience Dyad mission, data from Stroger, standards of behavior, including a system-wide change that's in progress, nurse communications, and data on Stroger Hospital Smart Box scores. The committee also received from the executive medical staff at Stroger Hospital and Provident Hospital and approved the Stroger and Provident Hospital medical staff appointments, reappointments, and changes. In closed session, we received further information that's privileged, and we're not planning to re-review that. And the minutes are presented now for board's consideration as part of a combined motion to be made later in the meeting. And that concludes my report.
Thank you very much, Director Guggenheim. I also like to acknowledge that Director Kim joined us earlier in the meeting. So Madam Secretary, please note her attendance. Next, Director Ryder will review the Finance Committee meeting minutes. Director Ryder.
Thank you, Mr. Chair. Yes, thank you, Mr. Chairman. The Finance Committee met on Friday, September 23rd at 9 a.m. The next meeting of the committee will be held on Friday, October 21st at 9 a.m. The committee considered the following action items, which are included in the minutes. Approve the request to execute a lease agreement with Hastings Center Office LLC and Illinois Limited Liability Company for administrative office space located at 1340 South Damon Avenue in Chicago. Conditionally approved 18 contracts and procurement items. Number 2, 7, 11, and 16 are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting whose fiscal impacts are greater than $1 million, which are highlighted for your information. We received and filed grant award related items. We received and filed transfer of funds. The committee received the following reports, which are also included in the minutes. Minority and women-owned business enterprise reports, the fiscal 2022 third quarter report of contracts executed under the authority of the Chief Executive Officer, and reported the July 2022 year-to-date financials. The action items, reports, and presentations from the committee meeting are included in the meeting minutes. If there are no questions on the information, the minutes are being presented for the board's consideration as part of the combined motion be made later in the meeting. And that's, unless there are any questions, Mr. Chairman, that's all I have.
Thank you, Director Ryder. We actually have 2 contracts that are being presented directly to the board for consideration. Ileana Mora, Chief Operating Officer of Ambulatory Services, will review the first contract, and then Dr. Peter Hart will review the second contract. Ms. Mora? Debbie, you're muted. Do we have Ms. Mora? Perfect.
Chair Taylor, can you see the screen with the transmittal on it?
We can see the screen, but I haven't heard Ms. Mora. Ms. Mora, are you there? Are you here?
Ms. Mora, are you present? Okay, she does reflect as present. She must have stepped away. I don't know, Charles, do you want to go over the transmittal in her absence?
Yes, I can. Good morning, Chair Taylor and Directors. Charles Jones, Chief Procurement Officer for Cook County Health. What you have before you is a request to amend, extend, and increase the contract for Cross Country Health for $3.5 million with a 1.17 FY22 fiscal impact. This is for various temporary staffings that will be needed with ACHN to help with the migrant slash refugees, individuals coming to within our health system, and it would include medical intake assessment, follow-up for primary care and specialty care, 6 visits, and and dental screening for pediatrics. Again, $3.5 million in extension for an additional 4 months into March of 2023. And both contracts presented to you today will require responsive letters from the Office of Contract Compliance. We have one back and one will be outstanding. Any questions? Thank you.
Well,
yes, Director
but I
Story.
don't think, with all due respect, the question is reimbursement for providing these services to asylum seekers. Is there anyone on the call that can respond to what we're doing to seek reimbursement for the services that we're now and have been providing to the asylum seekers who have arrived in our city?
Yes, I would defer to Mr. Rocha if he's on the call.
Mr. Rocha, you're going to cover that, right?
Sure, I'm here, yes. So we are right now working with IEMA and with the state to be able to finalize those structures with what funding comes forward. Right now, we are able to cover the startup costs from our operating expense, but we're hoping that we will be able to finalize an agreement with the state as IEMA and FEMA funds become available. But it's an ongoing discussion, and that is what we are pursuing, funding from IEMA and from FEMA. And so hopefully we will have an update for the board in the weeks ahead.
Thank you.
Thank you.
Mm-hmm.
All right, thank you all.
Okay, do we have Dr. Hart present?
Yes, good morning, Chairman Taylor and directors. I am Peter Hart, Interim Chair of the Department of Medicine. I'm presenting before you a request to increase the amount for the clinical services agreement with Rush and extend the agreement for 12 months. This is an ongoing clinical services agreement that allows Rush physicians and licensed physicians to provide specialty care at the Cook County Hospital. It also allows us to transfer patients to Rush for special diagnostic processes, particularly for cardiac imaging. We're requesting an amount of increase of $8,355,211 to cover this period of 12 months while contract negotiations are concluded by both parties. Thank you.
Thank you, Dr. Hart. Do we have any questions? Great. Thank you both for presenting and providing clarity. Next, actually, we have a resolution to celebrate County Care 10th anniversary. As you know, I'm sorry, Dr. Wellville, you have a question, Dr. Wellville?
I'm sorry, I thought I had taken my hand down. Nope.
Okay. Thank you. This was discussed earlier in the meeting in recognition, but we have a formal resolution. Madam Secretary, can you please read into the record?
I apologize. I was trying to do something. And circling back to the two contracts that were presented directly for the board's approval, I was confirming with Charles, it was my understanding that both have been found responsive for contract compliance. And Charles, can you just double confirm that for me?
Yes, that is correct. I'm bad there. So yes, both are responsive. So thank you very much, Debbie, for clarifying.
Excellent. Thank you very much. Okay, the resolution recognizing County Care's 10th anniversary, whereas Cook County Health, CCH, has a nearly 200-year history of caring for all residents of Cook County, regardless of its ability to pay. And whereas CCH is a staunch advocate of health equity and is committed to furthering programs and services that ensure healthcare coverage and access for all. And whereas the Patient Protection and Affordable Care Act, ACA, of 2010 allowed for the expansion of Medicaid eligibility to low-income adults, along with several other important healthcare regulations and policies. And whereas on October 26, 2012, the state of Illinois and County of Cook earned a Section 1115 demonstration waiver from the federal government that allowed CCH's Medicaid managed care plan, County Care, to begin enrolling and providing health coverage to adults in Cook County newly eligible for Medicaid under the ACA 1 year in advance of the ACA implementation date. And whereas, thanks to the collaboration between the federal government, the state and Cook County government, CCH's County Care was able to offer essential health care coverage to individuals a year earlier than statewide Medicaid expansion. And whereas in its first year, County Care enrolled 82,000 members across Cook County. And whereas County Care focused on enrolling vulnerable, uninsured individuals most at risk for falling through the cracks of the regional healthcare system, including low-income individuals, those who are unhoused, and those detained at the Cook County Jail. And whereas today, County Care is the largest Medicaid managed care plan in Cook County with more than 420,000 members. And whereas County Care developed and sustained a robust network of healthcare providers, including CCH facilities and many health systems across the region, offering members a broad array of locations to seek medical, dental, vision, and behavioral health care. And whereas County Care has received many accolades over the past decade for its operations and member services, including being ranked as the highest Medicaid managed care plan in the state by the Illinois Department of Healthcare and Family Services, and accreditation for demonstrating a commitment to quality by the National Committee for Quality Assurance, NCQA. And whereas October 26, 2022 represents the 10th anniversary of County Care serving the residents of Cook County. And whereas County Care has served more than 938,000 members over the past 10 years, facilitating more than 32 million medical claims and 75 million prescriptions. The health plan has also covered 781,000 well child visits and the births of nearly 43,000 babies. And whereas County Care continues to demonstrate its commitment to the health of its members and communities across Cook County. And now therefore be it resolved that the Board of Directors of Cook County Health does hereby gratefully acknowledge the entire County Care team for their significant contributions to the health and well-being of Cook County residents over the past 10 years. And Chair, that concludes the resolution.
Thank you very much, Thank you very much. I think it highlights the significant impact that County Care has had in improving the health and well-being of the residents of Cook County. Thank you. Really appreciate it. Next, Mr. Rocha will provide an overview of the next item, a proposed resolution regarding interim services provided by Dr. Karen Joshi and Dr. Rachel Rubin as co-leaders of CCH. Mr. Rocha.
Good morning, Board. And so this resolution is regarding the approval of the supplemental payment to be made to Dr. Rachel Rubin and Dr. Karen Joshi for serving in a temporary leadership capacity for the Cook County Department of Public Health during the pandemic. Before you today is a proposed resolution that will be presented to the Cook County Board for their approval. The action being requested by this board is to approve a motion recommending the Cook County Board approve this resolution. If the board is amenable to that, it will be included in a motion. I just want to give you some background. When a vacancy occurred in the Cook County Department of Public Health Chief Operating role early in April 2020 at the start of the pandemic, Dr. Rubin and Dr. Joshi assumed extra responsibilities as co-leads of the Cook County Department of Public Health. In addition to their roles as senior medical officers during the tumultuous period of April 2020 as our country grappled and braced for COVID, they were there to be able to provide common information in running the department. They were not eligible to receive additional compensation for performing these duties as additional leadership role under the current policies due to a technicality. This resolution addresses that inequity and recognizes their extraordinary work by providing a supplemental payment to each. So, Chairman, I would then turn it back over to you.
Thank you very much, Mr. Rocha. If there are no other questions on the minutes and the action items being presented for consideration, I am seeing none. We can move to the combined
Yes,
motion.
Chair.
Guggenheim, I don't see. Okay. Yeah, Director Guggenheim.
Yes, I actually wanted to make a comment on the previous resolution about the congratulatory resolution for county care.
Yes.
This is not in any way to diminish the importance of the sentiments expressed in that proposed resolution. I do actually think that the first clause should be amended in that we talk about, for nearly 200 years, caring for all the residents of Cook County. It seems to me that is, in fact, technically inaccurate. What we do is offer care to all residents of Cook County. We certainly do not provide care to the total county, even in terms of public health service, since that only covers the suburban Cook County. And so I think it's inaccurate in its wording.
Okay, thank you, Director Guggenheim. Secretary, we will make the adjustment. Does anybody else have any questions?
Thank you.
Director Guggenheim, you just raised your hand, and Ms. Director Guggenheim, you just raised your hand again, but okay.
Sorry, I was trying to cancel it.
No worries, no worries. That was on the beginning. Any other comments or questions? All right, thank you. If not, then we can move on to the combined motion. I'd like to entertain the following combined motion to approve the following: item 4A, August 26th, board meeting minutes; item 4D, September 23rd meeting of the Quality and Patient Safety Committee meeting, which includes the Stroger and Provident Hospital medical staff appointments, reappointments, and changes. Item 4E, September 23rd minutes of the Finance Committee meeting, which include the lease agreement with Hastings Center LLC for administrative office space located at 1340 South Damon Avenue, Illinois. Contracts, procurement items, grant award-related items, and transfer of funds. Item 5A, to contracts and procurement items. Item 5B, proposed resolution to celebrate County Care's anniversary. And item 5C, recommendation that the Cook County Board approve the proposed resolution regarding the supplemental payment to be made to Dr. Kiria Joshi and Dr. Rachel Rubin for serving in a temporary leadership capacity for CCDPH during the pandemic.
I'll make the motion, Garrison.
Second.
Thank you. The combined motion has been made and seconded. Madam Secretary, please take the roll call vote on the combined motion.
Roll call vote on the combined motion. Aye or nay, Director Curry?
Aye.
Vice Chair Deere?
Aye.
Director Garza?
Aye.
Director Guggenheim?
Aye.
Director Harrington?
Aye.
Director Kim? Director Kim?
Aye.
Thank you. Director Ketting?
Aye.
Director Munar is absent. Director Prendergast?
Aye.
Director Ryder?
Aye.
Director Story?
Aye.
And Chair Taylor?
Aye.
You have 11 yeas and 1 absent.
Thank you. The ayes have it. The motion carries. Thanks all. Next item is review of the Employment Plan Officer Semi-Annual Report, which will be presented by Kimberly Kraft, Employment Plan Officer. Ms. Kraft.
Good morning, everyone. The slides I'm going to present today relate to the EPO 16th Semi-Annual Report that I issued as required by the Employment Plan earlier this month. It covers amendments made to the plan, our training, monitoring, auditing, and investigative activities between January 1st of this year through June 30th of this year, although I did take some liberty to include some more recent activity throughout the report. It also includes goals and new initiatives for July 1st, 2022 through the end of this year. As a background, as you are all aware, CCH continues to have an unusually large number of vacancies due to turnover, a competitive job market, and the national workforce shortage. The ability to hire and hire quickly continued and continues to be a priority. So in this reporting period that we're covering, CCH leadership was interested in exploring employment plan compliant mechanisms to quickly hire enough permanent staff to maintain our operations. As you know, the employment plan is a living document. It belongs to us. As needs change, the plan may be modified to meet those needs, so long as the changes are lawful, meet the underlying principles, and provide transparency. So during this period, my office devoted a significant amount of time consulting with HR as it developed proposed modifications. 2 processes were developed and presented to my office and to the Office of the Independent Inspector General as temporary modifications to the plan to get us through the current crisis. These processes and subsequent amendments have been approved. So that leads into the first point here. So I do have a lot of progress to report. First, we have the revised hiring process. What is that? That is the modification that was approved that covers the vast majority of our hiring here. So positions that are covered by the general hiring process and the actively recruited process, I believe that's accounts for roughly 90% of the hiring we do are covered by this revised hiring process. A lot of different mechanisms were built in to support quicker hiring. You know, notice requirements were reduced. The screening process was changed to facilitate quicker hands-on involvement by the departments. The interview process was streamlined. The forms were updated to allow for a more efficient process there. The selection process also was updated to allow for quicker and more efficient selection process. So that's the revised hiring process. Second one is the revised hiring fair process. So as you know, hiring fairs have been an interest, for over a year now, since the summer of 2021. They've been used frequently. We did find, in the last reporting period that, it wasn't working for us the way we wanted to. So that was also addressed by HR in one of those proposed modifications. A lot of changes were approved. Significantly, instead of a pre-screening process happening before the fair, which took a lot of time, now candidates are reviewed, on a walk-in basis. We have, again, the same modifications to the forms to make it the interview process more streamlined. We do have the ability now to make contingent offers on the day of the fair, which was not allowed in the past. And then just more recently, different notice requirements, posting timelines have been reduced, all to facilitate that quick volume hiring. So those are significant developments. Now with the revised hiring process, once you have a new process, obviously, you need everybody to know what that process is before you can implement it. And so, we worked with HR in developing a comprehensive training module that would cover the revised hiring process. Leaders were presented with that training beginning in July, I believe, and the revised hiring process went into effect roughly July 27th, I believe, late July. And so that is, in the current reporting period that we'll talk about next time, but I did want to bring that up there. Positions that come to recruitment after that date are covered by this process. So that's something we're following now, and we'll have, observations to report next time. With the hiring fair process, training is in development. And when we get to the hiring fair section, we'll talk about what we have done as we continue to work on a comprehensive training for hiring fairs. I would also like to report that there have been technological improvements. I know in several of the past EPO semi-annual reports, I've advocated for, automation and technological improvements, not only to facilitate compliance, but to provide that transparency. And so there are two improvements that came out of the optimization that Ms. Amos spoke to earlier that I really wanted to highlight, being the digitization of the decision to hire form and packet, that it really goes to both transparency and to just really making the process a lot more efficient. And then the HR recruitment dashboard. Both of those, I believe, are very helpful, and I'm looking forward to seeing all of the other improvements that we'll be seeing in the near future. The other thing I wanted to highlight that I was very happy about, and I believe will have a huge impact in terms of compliance, is the role of the human resources business partner. That is a new role within HR, and I believe that they will. So there are 4 vacancies, 3 of them have been filled, but their role basically is to respond to employment and management concerns and questions regarding human resource processes and questions. So this is going to involve guiding management and staff on interpretation of HR practices, policies. That would include the employment plan, that would include the supplemental policies and procedures. And so I've already seen the impact of their involvement in the departments and helping them understand and implement the plan and the policies in a compliant way. So very happy to report that role has been added. Also happy to report, I know in several of our recent past semi-annual reports, I've spoken to just how very short-staffed we are in the employment plan office. In fact, in this reporting period that we're covering, we were down to 2 for a lot of the time, just myself and 1 analyst. So with all the changes and the activity going on, that made things pretty difficult. We were not able to get an additional analyst in the reporting period as I had hoped, but we were able to hire a program manager, which is extremely helpful. He started in May, late May. We'll talk a little bit more about him in a later slide. And then we had lost our information coordinator somewhere in the first half of the reporting period. That role is very critical here to our office because we receive a large volume of data and information from all over the place. And so that loss was dramatic and felt. And so with HR support, we were able to get that vacancy, in the pipeline and filled pretty quickly. Our new information coordinator started on September 12th. So very happy to report that. Next slide, please. Okay, so now we'll move on to our monitoring. As you know, when we monitor an employment action, we assist management by providing direction and guidance as processes unfold. We're aiming to prevent non-compliance in real time and provide kind of training as we go to prevent future non-compliance. We also provide guidance when we observe practices that don't technically violate the plan, but which don't fully conform with best practice. So, our monitoring is not always conducted in real time, and in many instances takes the form of document review. Either way, our process is to recommend corrective measures, either to hiring process participants and/or to appropriate HR staff as issues are identified. We continue to do that, although, with only 1 analyst and, how involved we were in all these changes and training, that was reduced somewhat from in past reporting periods. Without an information coordinator, I can't provide the same level of detail in numbers as we have in the past. I didn't see, a dramatic increase in any of the types of hiring process violations that we typically see in, general hiring process or actively recruited. I've talked in the past, and I'm sure the prior EPO has talked in the past about, sometimes interview questions are rephrased or explained, which is not allowed on the plan. Under the plan that continued, activities were conducted sometimes without the required notice or approvals. For example, notice of interviews or application reviews, or not using approved interview questions, or moving forward with interviews without having the interview list approved. And then sometimes we did identify processes after the fact where individuals who had participated were untrained in employment plan process, and therefore they had not been eligible to participate. Do I see a hand raised? I'm sorry, I'm busting ahead here.
It looks like it's Director Guggenheim.
Director Guggenheim, can I answer a question for you? Okay. 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 Moving ahead, the next area I wanted to highlight was with direct appointments. That those are our appointed positions. There are a lot. The hiring process there does not have a whole lot of structure to it. Obviously, it requires that the appointments can't be hired for political reasons or factors, but it also does require that they meet the minimum qualifications for the position. It does involve a process by where a packet, application materials are sent to my office and to the Office of the Independent Inspector General after a candidate has been identified, to allow us an opportunity to review the document that would support their qualifications for the job and, NPCs, that sort of thing, with an opportunity of a few days to raise any objections should we have them before the person is hired. So in the last reporting period, and then again in this one, we did notice several instances where there were hires that were onboarded without that packet being circulated for review to my office and to the Office of the Independent Inspector General in advance. I learned about those either through looking at orientation lists or hearing, new leadership announcements and meetings. So that, that's a concern. That's something that we have addressed with HR and don't expect that to continue. The other issue there is with, we did have one concern with one of the job descriptions that was updated to reduce the minimum qualification after a pool of candidates was already in front of our leadership. So that is something that we are currently working through. The IG's office, my office, and HR are working through currently. Finally, getting to the hiring fairs. This will be the last of the concerns that I discussed. As Valerie mentioned, there were some mistakes that were made in the August fairs, and even, there were two other fairs that occurred in the reporting period in January and in April. The January one was before that revised hiring process was implemented. At that point, we realized, that process was not working for us, and so we modified it. But in any event, errors were made. They all happened very quickly, as she said, all at the very end of August, and so there wasn't really a lot of time to kind of course correct and identify issues between those fairs. But we did get together with Human Resources, after those fairs had concluded, and we talked about, where the violations were happening and, how to, identifying those, how to prevent them in the future, that sort of thing. So what we're working on now, one thing is that, this was moving very fast. That, the initial hiring fair exception process was approved, but then there were several amendments along the way as it was being tweaked. And so those did not necessarily all make it into the main document, we'll call it. And so I think some of the errors that occurred were likely because, not everyone was looking at the most recent version, and some things, they were minor tweaks and some things were more dramatic changes. So right now, HR is working on formally including those in a comprehensive document so that we know everybody's looking at, excuse me, the same requirements. And then as far as training, I mentioned earlier, we don't have a formal comprehensive training yet for hiring fairs. Not that we didn't make a humongous effort toward getting that accomplished. It had been our intention to address hiring fair training in that rollout of the other revised hiring process. Hit a little snag with that and did not want to hold up the rollout of the revised hiring process. So that was kind of held back for that reason, so that we can fully develop another hiring process that will be compatible, the hiring Blitz process, which will complement and be compatible with the hiring fair. So that is also currently something that's we're consulting with HR as they fully document the proposed hiring blitz process to be presented for approval and then incorporated into the plan and into the training materials. So in the meantime, though, some workarounds were done so that, you know, we could provide our participants the best guidance possible, absent a formal comprehensive training program. So we do have these things called walkthroughs that happen 1 to 2 days before each hiring fair, where everyone who is required to participate in the fair, who's been signed up to participate in any capacity, they come for, you know, kind of a very detailed walkthrough of what the requirements are, what their role is, the flow of information, you know, on the day of the fair. They've also been given training on that new Brazen platform that Ms. Amos mentioned. So there is a lot of training that happens. You know, I'd call it informal training. But really, where a lot of the violations have happened that are more difficult to correct or more time-consuming to correct, really are ones that happen before the day of the fair, so in the planning process. And so what we did as to address that even before the August fairs was to come up with a request, planning, and approval process whereby all the stakeholders come together. There's a new form that's been developed to sit down and fully document the plan for the fair to make sure that all the I's are dotted, T's are crossed, and everybody knows what they're doing, and it's going to be a compliant fair. But again, things were moving very quickly, and that process was being kind of developed as these fairs were rolling out. So they didn't per se work as anticipated for these August fairs, but I fully expect that they will work as intended for all future fairs. And as an aside to that, HR is also currently finalizing some job aids that had been developed for the hiring fairs, making sure that they're up to date and include all recent amendments to the process. And those will be released even pending that final comprehensive training that will be circulated by the LMS once the hiring blitz process has been approved and both the hiring blitz and hiring fair training module have been circulated. So all of those things together, I think, will support compliance in the future. Next slide, please. In terms of our supplemental policies, we also monitor those. There's several of them, and I've just identified just a few here. The interim assignment and interim pay policy I've mentioned in several past semi-annual reports that, you know, that policy and the form that go with it really need an update. I provided a lot of detail for why I believe that to be the case in the report. HR agrees that the policy and the form need to be updated. It's been, you know, near the top of their priorities for a long time now. But as you know, we're in a crisis and there are a lot of competing priorities. But it is at the top of policy-wise. It's my understanding that is the top priority in terms of policy updates. Discipline. So discipline, we monitor, you know, every reporting period. We cover it every time. This time we reviewed, there were a total of almost 300 corrective actions. That includes both counselings, which don't technically count as discipline, as well as formal discipline. Out of those, we reviewed about 100. And, you know, when we monitor, we're not looking at only what is in the black letter of the policy itself. We're looking at what do the personnel rules say? What are those, you know, what is required? What administrative policies are required to support this? And are they following all of those? Is the paperwork a complete, transparent packet for what HR needs? And so as we looked at those, we did identify a total of 70 policy violations or other administrative deficiency. So in total, it wasn't 70 violations, but 70 violations and or other administrative deficiencies. We did not notice, again, our numbers without having the information coordinator, we did not see a dramatic decline or really, increase of discipline. But just to give you some bullets of what we saw, it's not really anything unusual from past reports, but sometimes required approvals, meaning signatures on the form were missing, or maybe the signature came late and didn't demonstrate that the approval happened where in the process it was required to happen. Incomplete forms or packet submissions, it's meant to be a full packet with all supporting documents. So maybe sometimes they, forgot to attach a witness statement, or, one of the notices or some part of the packet was not initially provided. Sometimes we notice timeliness issues where the packets weren't sent to HR by the time that is required by the policy. And then, like I said, some other administrative things. In terms of overtime and training opportunities, really not a lot to say here. Those two policies require unusual in that there's not a form where you fill out your NPCC every time you assign overtime or training opportunities. Because of the nature of those policies, NPCCs are submitted by department heads just twice per year via a red cap survey that comes to them through email. It's a department head requirement. So the last one was due June 15th. And so, we're still not in full compliance with that. We've sent out reminders over time, and we're getting a lot closer. I believe as of sometime in September, we were still had 28, maybe still outstanding, and we will continue working to get full compliance with those. Next slide, please. Moving on to investigations. Investigations are, another big part of what we do here. When someone believes there's been a violation of the employment plan, they report it to our office. During this reporting period, there were 8 new investigations opened as a result of information coming to our office. We closed 6. That's not necessarily 6 of the new ones, that's just 6 total. As I've reported in the past several semi-annual reports, and even the prior EPO reported in several of her past reports, investigations require a lot of work. And so at this point, we do have a lot that are pending, 45 plus just since 2020, and then even have some still existing since prior to 2020. So it's really important to be able to have the staff to be able to address those and devote the time necessary to look into these complex matters. Now, some good news to report. I told you I would come back to our new program manager. So we recently hired Andrew Jester as the program manager. He came on in late May. He comes to us after serving for over 10 years in the Cook County Office of the Independent Inspector General, where he focused on both compliance matters and investigations related to the employment plans of various county entities. So that having him focused on our investigations will be very, very helpful, as is the fact that after he arrived, we did propose a series of modifications to the employment plan, which will better enable us to triage and administratively resolve complaints that don't address underpinnings of the plan and supplemental policies. So really making our process a lot more efficient. And so with those things in place, I do expect that we will be able to really start making a difference and getting through a lot of these investigations very quickly. Next slide, please. Auditing. So we didn't complete any audits in this reporting period, but we did initiate one. So as Valerie Amos mentioned earlier in the HR section, there have been a lot of contractors brought in the past several months to assist with recruiting and screening, et cetera, helping facilitate our hiring processes. So there is one of the supplemental policies does cover third-party providers. And so we are in the process of collecting information to see, what that looks like. So we've got, collecting documents, reviewing compliance with what the policy requires, including do we have NPCCs for everyone, and then really also looking to verify that all of these contractors that have been brought on to assist with our hiring process are fully trained for their respective functions, because they are required to also follow the employment plan when they are assisting us here. So we will definitely be able to report that in the next semi-annual report. Next slide, please. What's coming in the future? So I mentioned this a little bit earlier. There is a hiring blitz process that we have been consulting with HR on as they fine-tune that for proposal for inclusion in the plan. It'll be another valuable tool that is a little bit less complex than hiring fairs and requires less coordination between HR and the hiring departments that might be a desirable option in many instances when we're trying to facilitate some mass bulk hiring. So that be on the lookout for that. I already mentioned that HR is working on comprehensive documentation for those 2 temporary revised processes. Again, that's going to help with compliance because then everyone will be looking at the current version of the process. I talked to you about the employment plan office investigations modifications that were approved. Those haven't formally been included in the plan yet as an amendment, but we expect that they will be in the near future. Again, interim assignment policy and form updates are very high priority, so I would expect to see that in the near future. As far as training, training has been we're a little bit behind in various types of trainings. For example, our all-employee training that also gets submitted annually. There were some hiccups, and it goes into detail in the report. But in any event, getting those in a format that is compatible with our new learning management system presented some challenges. But it's my understanding that that's in the final fine-tuning and will be circulated to employees very shortly. And so definitely for HR training, for example, they get annual refresher training. That's been really difficult to accomplish, since COVID and with all of, the challenges with hiring and competing priorities. And so, we have been working with HR to come up with a workable solution rather than, requiring 4-hour attendance at 4-hour trainings. My office will jump into their staff meetings and present, give short presentations on discrete topics, when they're already together. And we'll continue to think of other creative solutions to getting them the refreshers that they need. And so EPO initiatives, we are at this point, now that we are staffing up, we are going to undertake a review in our department of how to optimize, tons and tons of data comes into the office. And, as Ms. Amos has, I'm sure, described for, HR data in the past, similar challenges. We want to really figure out where we can share data, all the sources of data. And so we'll be looking at that over the next couple months as well. And of course, staffing is increased, and we're still hoping to get 2 more analysts in the next fiscal year, which would really help. As far as another thing that I feel it's really necessary to push and keep pushing is updates to our website in terms of the employment plans content, and just making sure our job descriptions are up there as they are required to be, our current job descriptions, which I know Valerie could provide more information, but I know my understanding is one of the contractors is working on that actively. And so that should happen very soon. Next slide, please. That's all I have. Does anyone have any questions? Thank you.
Thank you very much, Ms. Kraft, for the very thorough. Actually, we do have Director Harrington. Would you raise your hand?
Yes. I guess a request more so than a question. I want to thank you for your report. You covered a great deal of information, and it was covered very quickly because I couldn't catch everything that you were saying. But I'm not sure if you're telling us there is a problem or you caught some things that need to be addressed, and you'll work with staff to address those things. And I believe the latter is the case. What I would request, since we're going into the last quarter of the year, is to provide an update to this report to let us know what has happened subsequent to your report. That may give us a better idea to see what's happened moving forward. That's all.
Sure, absolutely. And like I said, as we, we're not here just to point out errors. We're here to identify them and then, work with whomever we need to work with to prevent recurrence and, to really support, implement whatever needs to be done to support compliance going forward. So we really have been working closely with HR on a lot of what was identified in this report already. So I definitely will be happy to provide an update.
Thank you. Director Story.
Thank you very much.
Thank you. My question centers around, given the challenges that we are having, not only at CCH, but in the healthcare industry to address the onboarding process. With all due respect to compliance, et cetera, what role does the OIG and the compliance office today in the current state, what is happening to enhance the process so that this organization can meet the needs of its missions by onboarding professionals who can take care of the patients and families that we serve? I can appreciate, quote, compliance, but I don't see it as a vacuum. I see it more as, where's that intersection after all these years? What changes have been made that will enhance our ability to onboard those individuals that we need to take care of, to drive the mission at CCH?
Sure, happy to answer that. So as I mentioned, the employment plan belongs to us. It is a living document. So as needs change, operations change, it can be updated. We still have to just comply with the plan's fundamental principles. We have to make sure that we're being lawful, we're being transparent, right? And so there is an amendment process in the plan. And, that is what, our leadership here utilized in proposing these temporary modifications to get us through the crisis. And so, when the plan is going to be amended, that does have to be approved by my office and the Office of the Independent Inspector General. We're looking at it as, does this still meet all of the underlying principles, right? And so from my perspective, my office and being part of the Cook County Health team here, knowing that I would be one of the approvers, worked very closely with HR throughout the process as they developed these proposals for the revised hiring process and for the revised hiring fair process to help move that along quickly and to get those initiatives underway. And so I believe I did touch on some of the changes, but notice requirements, some notice requirements were waived, some were cut in half. The screening process, for hiring fairs, the advanced screening process was completely eliminated to allow people to just walk in at the fair and get their interview and get a contingent offer the same day. That was not in the original process for the hiring fairs. So there were a lot of the forms were modified to allow for quicker scoring or to kind of eliminate the parts of the form and process that often resulted in back and forth with HR after the fact to make corrections. So there were a whole lot of different things. Selection meetings, for example, with the revised hiring process are no longer required under circumstances where you have, more current vacancies than the panel has recommended for hire. So there were a lot of mechanisms put into place in these revised hiring process and the revised hiring process. I know it's confusing. They're very similar in title, to really support quicker hiring. And as the processes unfolded and as additional requests were made to even further help with that, they were considered and approved. And so, for example, there was a 30-day notice requirement for hiring fairs, and now it's down to 7. And so, we've been very involved and flexible in approving all of these proposals to support HR and getting people in the door.
And I trust that HR is grateful for the amendments or the adjustments that you've made. And some of these you referenced, these modifications have been temporary and some have been eliminated. I would ask the question going forward that as the compliance office continues to make certain modifications, I would hope that you would take a deeper dive into the plan to see where there are opportunities to permanently eliminate as opposed to making adjustments or modifications, so that indeed the onboarding process can be further streamlined going forward in order to once again support what your colleagues are doing in HR. I think that would be something that I would be interested with respect to Director Harrington's comment about the fourth quarter. I would appreciate hearing more about the adjustments to the plan, because as you said, the plan is a living document, it's organic, and it's probably aged if it's organic. So some components of it are probably outdated. You might agree or disagree, but I would be interested in hearing more about how this living, breathing document can be updated in 2023 that will enhance our ability here at Cook County government to support the mission of Cook County Health and Hospital System in the future state.
Okay. And we will definitely communicate with HR about that. As I mentioned, I don't own the plan. I don't make the plan. I approve, the plan so long as it complies with those principles. But I'm happy to continue, as we have been, working with leadership on suggesting or providing input on changes that could be made that would support us going forward. Absolutely.
Thank you.
Thank you for responding to my questions. I appreciate your answers.
Oh, no problem.
Thank you. Ms. Amos, I think you had something to add here as well.
Absolutely. So thank you, Kim Kraft, for your comments. And thank you, board, for your questions and comments. Definitely those amendments that were expressed by Ms. Kraft, those were amendments that came from this office. Those were items that we saw that needed to be modified, part of our optimization to really streamline and enhance and accelerate hiring. So working through that very legalese type of document is really challenging for someone, but most importantly, I think we have a very significant opportunity to make those enhancements, as you mentioned, Director Story, because we will definitely follow the unbiased hiring, no political consideration. We want fairness and consistency for all candidates. That is our goal, and that was one of the drivers for me submitting those amendments to OIIG in the past. And so we will continue to definitely lean this out so that we can be more contemporary in the market. We want to be like others and then better than others. And so here's our opportunity to kind of strip away some of the, the former guard, if you will, but ensuring that there is still compliance based on the principles of the employment plan and through our revised hiring process. So compliance, but also contemporary. So we need to get to those 2 C's and make them balanced instead of one being stronger than the other. Thank you for your time.
Thank you very much, Ms. Amos. And thank you very much, Ms. Kraft. Do we have any further questions? Comments? Thank you. The
Have a good
next,
day, everyone.
I'm sorry, I don't see a hand. I'm sorry.
Oh, I was just saying have a good day, everyone.
Oh,
Signing
thank
off.
you. Yeah, thank you. The next item is a quarterly report from CCDPH by Dr. Lamar Hasbrook, Chief Operating Officer of CCDPH. Will provide an introduction of the report. Dr. Hasbrook.
Thank you, Chair Taylor, and good morning again, directors. First, let me also congratulate my colleagues, Doctors Rachel Rubin and Joshi, and certainly recognize their ongoing contributions. So this morning, I'm going to introduce a key member of our team, Dr. Alfreda Holloway Beth. She is the director of our unit for epidemiology, our epidemiology unit. And she's going to share for our quarterly report to you. She's going to share two very significant initiatives that will really continue to help both the department and CCH be a data-driven learning enterprise. One is the first ever Cook County Health Survey, and the other will be the Cook County Health Atlas. And you may expect to hear something. We're trying to plan maybe a presser sometime next week with the Office of the President. So with that, I'll turn it over to Dr. Holloway Beth.
Thank you, Dr. Hasbrook. Good morning, everyone. I would like to thank the leadership for the opportunity to discuss the Health Atlas and our survey. Next slide, please. I think Debbie, sorry, I don't see the slide.
Doctor, can you see the screen? I've got it on the second page of the deck.
Thank you. With funding provided by the CDC Health Equity Grant, the Health Department is conducting its first adult population-based surveillance study known as the Cook County Health Survey. To learn more about the survey, please visit us at cookcountypublichealth.org/health-survey. The survey is a tool used to collect information from a representative sample of suburban Cook residents. The 2022 questions include the following topics: general health status, access to health care services, food insecurity, substance use, cancer and other screenings, chronic conditions, distracted driving, emergency preparedness, financial security, sexual behavior, and social cohesion, to name a few. These questions provide information that supports the CCDPH strategic plan, community health assessment, and public health programming. The survey is available in both paper and web-based versions. They are in English and in Spanish, and all data collected are self-reported and confidential. The data collection period is from September 15th, 2022 to March 31st, 2023. The survey takes about 25 to 30 minutes to complete. Next slide, please. Residents will receive up to 4 mailings requesting their participation. First, an invitation letter. Postcard, the second is a postcard reminder. The third mailing is a paper version of the survey with a web option. And the fourth mailing is the second postcard reminder to complete the web version of the survey. All mailings are in both English and in Spanish. And here is an example of our invitation letter. As you can see, Dr. Hasbrook is asking people to participate in the survey. Next slide, please. There are multiple ways to complete the survey. One as a paper survey and also as web-based. Once invited to participate, the web-based survey, in the web-based survey, residents can complete the survey on their desktop, tablet, or smartphone. Participants log into the survey at cookcountyhealthsurvey.org using the invitation code from the mailings. The survey does not have to be completed in one session, but instead can be worked on over several days at their leisure. Next slide. The survey has been out for 14 days. We have 2,073 surveys completed, which is approximately 25% of our goal for data collection. Thus far, we see that 69% of our respondents are white, 14% Black, 8% Asian, and 12% Hispanic. The highest proportion of respondents fall in the 45 to 64 age range. 2/3 of the respondents identify as female, and those reporting an income of between $75,000 and $200,000 have been the highest in our respondents thus far. Information from the survey, as well as other public health data, will be shared with the general public via our newly launched data portal known as the Cook County Health Atlas. Next slide, please. We have partnered with the University of Illinois at Chicago, their School of Public Health, and Metopio to design and deploy an online atlas. The atlas is a platform for sharing a wealth of information to improve health awareness and decision-making. The atlas is a searchable database that anyone can use, easily access, analyze, and download community-level health data from over 120 municipalities, hundreds of zip codes, and by census tract. Our users will be able to see more than 100 indicators of health and visualize them in maps, charts, graphs, and tables, absolutely free. Next slide. At this time, the atlas contains 6 primary categories for health indicators: quality of health, risk indices, and population characteristics. The atlas can be found at cookcountyhealthatlas.org. Please visit. Next slide. As the atlas is a continual work in progress, we will roll out data in 4 phases. Phase 1 is complete, and we have 146 indicators that come from a variety of places, including our community health status assessment, quality of life indices such as the social vulnerability index, chronic disease prevalence estimates from the CDC places data, and information that comes directly from our opioid epidemiology program. We are working to integrate vital statistics data, environmental screening, hospitalization, and of course, our survey data into the atlas. Next slide. Here is just one example of how to use the Health Atlas. We can evaluate the poverty rate by municipality as an example. The map shows that Cicero, Illinois has a poverty rate of 13.8%. On the right side of the screen, you have the options to stratify the data by the full population of suburban Cook County, race, ethnicity, sex, and by age. There are more options to explore the data at the top of the map screen. Next, we will see how to compare the poverty rate of Cicero, Illinois to all of Cook County. Next slide. Sorry. The line graph shows that the 5-year moving average poverty rate is higher in Cicero than when compared to Cook County as a whole. Cicero had a steeper increase in poverty and a more dramatic decrease, which then equaled to all of Cook County by the end of the 2026-2020 data period. Comparisons like this help with descriptions of trends, but also generate questions to be explored about the community. Something like, were there economic investments in the community that led to the decrease in poverty? Did poor people move out of the community? In addition to using the stratification function that was seen on the previous slide, we can explore our indicators using a health equity lens. We would answer questions like, are there disparities by race, age, or sex? We welcome you all to visit the Health Atlas by going to cookcountyhealthatlas.org. Thank you. Next slide is just thank you, sorry. Director Harrison.
Excuse me, we have a question from Director Harrington before we move on. Director Harrington?
Yeah, I have several questions. You indicate that there's a pre-survey incentive. What is the pre-survey incentive?
So each invitation letter comes with a $5 gift card from Amazon.
Oh, okay. And when I looked at the slide on race and ethnicity and age, it seems like the minority population in suburban Cook County, and I don't know, the numbers might be underrepresented, and you're hoping to increase the number of minorities, racial and ethnic minorities that participate in the study. And it's, again, it seems like the people that are completing the survey are 65 and older. And so this, how's it going to be representative of the actual population? That's what I'm trying to get at.
Yeah. So in our jurisdiction, our population does kind of follow what the survey is doing. Most surveys do try to have an overrepresentation of minorities in general. We have done several promotional campaigns to help with this. So my EPI team goes out to our advisory councils meetings through CCH is one mechanism. We are planning on doing a social media blitz, and also our communications team will be sending out text messages in areas where there are more minorities in the near future as the survey determines we want more participation in certain areas. So that's kind of some of our strategies to get more people involved.
Yeah, and my last question is, who do you anticipate would be the actual users of the Atlas?
I think just kind of from an academic standpoint, we may see more academicians, students, people who are applying to various grants related to public health, but not all of our data is just public health data, data related to, say, for example, criminal or crime statistics and things like that. So law enforcement may be interested. I think we can promote the Atlas for journalists. I know that with the Chicago Health Atlas, a lot of times WBZ uses their data and information to help with their story. So I think a lot of people will be interested in this. We just have to let them know about it.
Yeah, and would it be possible to work with the city to get a more complete picture of the county, since they have an Atlas and you have an Atlas?
Yeah, we are actually working together. So Chicago and our Atlas are on the same platform. So when you go to our homepage, for example, if you're looking for Chicago data, you just click onto the Chicago link. So we're closely linked together, and we've been working together.
It's good to hear. Thank you.
Just briefly, let me just add a couple of things. So the survey, you mentioned some of the underrepresented groups. So this is a survey where it's not like we can just drive people to take it. There's been some sampling models done. And so it's a household survey, one person per household. And so you're only eligible to take the survey if you're invited to take it. So it's not like we can kind of gin up folks and say, let's start taking it. And so that's the modeling strategy there. But we will continue to do social media and outreach to make sure we get the representative groups, filling out the survey.
Thank you.
Looks like there may be another question, Director Kenning.
Yeah, just a suggestion. I had the same question that Joe did on seeing this, if it strikes one. So when you present this in the future, if you present it also with baseline data as to what the overall population looks like, to give us a sense of how it's approaching or deviating from the actual distribution, I think would be helpful.
Thank you.
Great idea. Thank you. Okay, looks like there's no more questions unless Director Harrington, you have a second one. Your hand is still up.
I'll lower my hand.
Okay, thanks.
Thank you all.
Back to you, Chair Taylor.
Thank you. We really appreciate it. It's a lot, as we can know, a lot going on and a lot of activities here. So we really appreciate it. The next item is my report, and as many of you may know, given the terms of our directors, we will have a number of vacancies and changes that will exist over the next few months, and a number of new directors joining us, and we will have some others leave us. That said, the appointment of Dr. Jay Bott, to fill the seat currently held by Director Guggenheim, was approved and ratified by the Cook County Board on September 22nd for a 4-year term beginning October 8th. Given that this will be the last board meeting for Director Guggenheim, and I would like to take this opportunity to recognize her work and the efforts over the years. Many of you may not know this, but she has served on the CCH board for over 9 years, since being appointed to fill a partial term in 2013, and has been reappointed twice to the board. The Director Guggenheim has served as the chair of the Quality and Patient Safety Committee since 2015. She has also served as a member of various committees over the years and regularly attends all the meetings, even those for which she does not serve as an active member. Dr. Guggenheim started her career in healthcare as a nurse. She then went into policy development and regulatory affairs with leadership roles at the American Hospital Association and the Chicago Community Trust. She has spent the majority of her life working on initiatives to advocate, educate, and improve the health of our residents. The CCH board, administration staff, residents of Cook County are all fortunate to have Dr. Guggenheim serving on this board for the past 9 years. She has been dedicated and has provided an incalculable amount of her time, expertise, her passion to serve and carry out the mission of this health system. And as even for today, you notice her attention to detail and her attentiveness. Dr. Guggenheim and Director Guggenheim, we thank you, we appreciate you, and we will miss you. This is not scripted, so I'm going to ask you, Dr. Guggenheim, did you have any words or any thoughts to share with us today?
Thank you very much. It has been an honor to serve, and I hope the board will continue in demanding sort of high standards and close monitoring of the activities, both the healthcare plan and the entire system. Thank you very much, everybody.
Don't go, Mary, don't go.
Yes, we gotta say it. Director Harrington.
Yeah, I had the opportunity to meet Director Guggenheim when I was working at Rush. And the one thing that I found about her, she's consistent in terms of her attention to detail. And it's a much needed skill set that we will miss greatly.
We appreciate that. Director, Vice Chair Deere.
Thank you so much. I also want to say thank you, Director Guggenheim. Since I've been on the board, you have been on the board, and I could always count on you making sure that everyone was authentic. And so thank you for your knowledge base. Thank you for your passion and your commitment regarding the people that we serve. And your voice will certainly be greatly missed. I just want you to know you are appreciated.
Here, here.
Thank you so much.
Next, Director Prendergast, I believe.
Yes, I just want to personally thank Director Guggenheim for her leadership. Particularly, I had the opportunity to serve on her quality on the quality committee with her, and I appreciated her leadership, not only her attention to detail, but just as a fellow healthcare provider, just understanding just the importance of quality. And I just want to thank you for the years that I've been able to work with you, and hope that we can be able to continue to communicate and as the years and days go on. Thank you.
Thank you very much, Director.
Director Ryder.
So, without sounding too cliche, Mary Guggenheim's been the conscience and the moral compass of this board, and everyone should know that when it comes budget season and we have in-person meetings, Mary Guggenheim attends all of the meetings relative to the impacts of Cook County Health on its budget at the Board of Commissioners. She's, the times that I've attended, she's been there before me. Even just to, she's there to observe and to make sure that she's fully informed about not only what we do when we meet as a board, but also as it impacts the Board of Commissioners. She's been an advocate for both personnel and policy, and to make sure that we always come out on the right end of things. And I've seen Mary struggle with decisions when we've had to make difficult decisions, because she has been and will maybe have been the most thoughtful person that we've ever had on this board. So we've all been much better served by having Mary help lead the way.
Here, I in the time we've had a chance to work together, I share the sentiments of all expressed, and Director Guggenheim, we really appreciate it. I get a feeling we may see you in public testimony or on the other side of this, continue to hold us accountable.
Thank you.
Next, the next item is the report from the CEO, Mr. Rocha.
Thank you so much. And also, I would like to start by recognizing Dr. Ada Mary Guggenheim's service and her tenure today, and her being her last meeting. I cannot overstate how invaluable Director Guggenheim's leadership was to our health system, to our organization, and to our quality. Throughout her entire career, she has graciously donated her time volunteering for maternal child health initiatives, among other causes, and serving for the board of directors at the Sprague Institute. While nearly a decade of service to the health system, she has served as chair of the Quality and Patient Safety Committee since 2015 and has seen us through 10 budgets and 4 strategic plans. She has graciously shared her extensive knowledge of clinical services, health policy, and regulatory matters for the betterment of our health system. As our quality champion, she always asked the right questions. She always challenged us to aim higher, to do better, and to strive for excellence. For nearly a decade, she was a steady hand guiding us and our organization during the voice of transitions and growth. Director Guggenheim was a staunch advocate for our patients and our staff. Her commitment to advancing the health and well-being of Cook County was unwavering. On behalf of all of our health system, all of our employees, and everyone that comprises the Cook County Health family, as broad and as expansive as it is, we want to thank you, Director Guggenheim, for your tireless work and your support. Your efforts have made a true difference to Cook County Health as we strive for quality in those that we serve. We're so grateful for everything that you did, including all the nudging and pushing you did with staff to make sure we are better. A small token of appreciation. We have a framed historical keepsake that will be shared with you very soon. Again, thank you for your service. Thank you for everything you do for us. And thank you for making us be better. With that, I will see if, again, Dr. Guggenheim has made her comments. I don't know if she wants to add anything else, but we will make sure that we get you that keepsake. And then we will now be moving to the portion of my report. I want to recognize a few staff members to directly bring some updates to the board on some key initiatives that we've been working on throughout our organization. So that first one that we have so proud to be able to move forward is our healthcare for asylum seekers. You know, Illinois has a very special place in the pursuit of freedom, from being one of the endpoints of the Underground Railroad to being able to be the state that the president hailed from, that ended slavery to electing the first president who was a Black American in our United States, and to make that historical marker. The road to freedom and being able to advance freedom is something that Illinois has long stood for, and that is something that is going on today. As we have been charged to be able to provide assistance for individuals who are seeking freedom, fleeing a communist country in which political and economic persecution is forced upon these families. These individuals are individuals who have gone through our Homeland Security process and whose application has been validated while they are working to seek that asylum application. They sometimes need healthcare assistance, and our system has been prized with being able to offer that, as our state of Illinois has welcomed the asylum seekers who are seeking freedom and to live their life in a country that is run by democracy, and people can live to be free and live their life in equitable terms. And so with that, I want to bring forward Eliana Mora, our Chief Operating Administrative Officer for Ambulatory Care Services, to give you a quick update on our healthcare for asylum seekers update.
Good morning, Eliana Mora with Ambulatory Services. Thank you for allowing me the opportunity to tell you a little bit about the initiative that we pretty much started overnight. As
Ms. Mora, we can't hear you too well. Can you speak up a little bit?
Yes, can you hear me now?
Yes, that's better.
All right. Good morning. I'm Eliana Mora with Ambulatory Services. Grateful to have the opportunity to tell you a little bit about the services that we launched pretty much overnight. September 6th, we got a phone call, the state of Illinois and the city of Chicago, hoping to partner with us given our success in running large-scale operations like the mass vaccination site. They reached out to us asking if we would help them in providing the medical intake assessments for the asylum seekers coming from the Texas border. So we were lucky enough to have an ambitious and very talented Cook County Health team to respond to the need. And we also were lucky enough to have a beautiful space on the second floor of the Belmont Cragen Health Center that was not yet occupied to run the Refugee Health Center. So we are now in our third week, or actually 3.5 weeks in of the operation we've stood up. To date, actually as of yesterday, end of date, we have cared for 1,161 patients through 1,692 patient visits. And those are all medical intakes, both men, women, and of course, children. We are also very proud of the program that includes prescription services. As we all know and have read in the news, our asylum seekers that are arriving have been traveling for quite a lot of weeks, and in some cases months. So they are arriving most of the time with actually only the clothes on their back because of the journey, and also although they may have traveled with some of the prescriptions, they were taken from them at the border. And so we're very proud that we're able to provide them also prescription medications upon medical intake. We set up delivery of their medications to the shelter that they are staying at that very night. That same night, their medications are delivered to them. And we have about an 87% success rate in making sure that medication reaches the patient. Moving on to the next slide, this just gives you a sense of some of the services that we're providing in terms of the pharmacy side. We are offering all of the children full vaccinations so that they can enroll in school and complete their school physical forms, as well as a dental screening. So they leave our health center with all of the documentation and requirements meant to enroll in school. We also offer, of course, all host of lab services as well, TB screenings, as well as every A patient gets an adult gets an HIV rapid test, and a host of all the other labs that you see listed there. The next slide gives you a sense of the staffing that we're looking to staff. We are currently running the entire operation with our own ambulatory staff. A huge kudos to them, and we will go thank them in the final slides. However, we know that we need to onboard staff to help sustain this over the months to come. The state of Illinois is supporting some of the staffing, and then your support will help us to continue the staffing through that cross-country contract. And of course, we are continuing to seek funding resources from the state to help support the ongoing Refugee Health Center. The Refugee Health Center is a bit more complex than our current health center operation that we would normally run. That is mainly due to the fact that this is a transient patient population. So when they register with us, they do not have a phone number to reach us, and the address they're registering is the shelter of which they are currently at. They come to see us within 24 hours of arrival at that city shelter. But then about 3 days later or 2 days later, depending on how many more Texas buses come from the border, they are transported out to various hotels in the Cook County area. And so the need for us to have care coordination and patient navigation increases by multitudes, because we need to track the patients. As you know, we just ran labs on many of them, and we need to be able to track those that have irregular lab results. And so our infrastructure around care coordination and patient navigation is much more robust than we would normally have, because the entire population is in need of patient navigation, where in a normal health center, we might only have the highest risk patients in needing of that service, but otherwise, in this case, it's the entire population. So you will see a good host of patient navigators. You'll also see the need for transportation and logistics. We coordinate that with the city of Chicago and the state of Illinois. There's significant logistics in terms of we of course are taking care of everyone for medical intake, but then there become the folks that we need to bring back because of an irregular lab, or folks that came to see us, and then 24 hours, 72 hours later, maybe even a week later, they have an urgent need, and we have to transport them back to either our health center or our hospital for services. Next slide. This gives you a sense on the left-hand side what it looks like when you come to our Refugee Health Center. Everybody gets screened for COVID. If they have COVID-like symptoms with a rapid test, of course, they are then registered. And then we do the intake and the medical assessment. We are lucky enough to have our own providers that have been working extra sessions and extra time to do the medical intake assessments. And then, of course, as part of their discharge, we provide them instructions on how to reach us. We've set up a phone line directly to the Refugee Health Center as a means to reach us after hour. And then after hours, we have after hour coverage on that phone line as well. There have been some cases, a handful probably each week, where the assessment shows that we need to transport the patient for urgent reasons to our own ER. For the most part, though, excuse me, for the most part, it is a very healthy patient population. We are not seeing major needs for immediate surgeries or immediate really high acute care whatsoever. However, there are just a handful per week that do need medical transport to the ER via ambulance. As I mentioned already around care coordination, these are the efforts and the reasons why we need care coordination. Again, mostly the transient nature of the patient population as well. Lastly, we know that many of the families will be staying in the Chicago area. We are also the first medical touch that they are experiencing here in Chicago and the Cook County region. And we are also working to offer Cook County Health as a medical home in any one of our ambulatory health centers for both the adults and the pediatric patients. Overall, the patients are very grateful for the services they're provided at Cook County Health. It's a warm welcome. I would say all of the staff that have volunteered also feel just great about the opportunity to be able to serve. And the patients feel that compassion. They feel the service received is really excellent and have nothing but just gratitude for what we were able to provide them. And therefore, they themselves ask, it is part of our process to let them know about a medical home, but they themselves ask if we are able to continue service for them after the medical intake. Additionally, we, upon being at the health center for their first medical intake, we do enroll them in Medicaid. And we also have other DHS coordinators on site that offer them other services like food stamps that they might need or other social service benefits. Next slide. This just starts our thank you slides. I want to add Dr. Sharon Welbill to the thank you slide as well. This is our core team, that the ambulatory team that has really worked on the front line. It feels like every emergency response that comes to Cook County Health. That includes our mass vaccination staff sites. This is the same team that stood that up. The monkeypox response, this is the same ambulatory team that responded to that and continues to operate that, as well as continues to operate our vaccine efforts. And this is the same staff that responded at the late hour on Tuesday night to open up the site to care for the first 90 patients the very next day. So we are lucky at Cook County Health to have such dedicated, talented, and committed individuals that allow us to respond, that also are, really being recognized as an organization by the state and the city as the first people to call in the event that we need to respond to an immediate healthcare need. Next slide. Refer all of the providers that have volunteered to take shifts at our refugee health center. We have been open Monday through Friday, but we will start being open on Saturdays starting tomorrow. The number of buses have not decreased, but continue to increase. Therefore, the need for us to be open on a Saturday is important. So we're able to care for those patients and for Monday operations to run a little bit less congested. The teams have been working a minimum of 12 hours a day. We start at 8, hope to be out by 8, depending on emergencies, sometimes are out by 10 or 11. So huge gratitude to the patient care teams. Next slide as well is our continued group of providers that have pitched in, come in, graciously helping us. And for that, we are grateful. Thank you.
All right, I'll go on to. Go ahead.
Yeah, just thank you so much, Ms. Moore. Now we would like to have Dr. Welbill proceed to give us an update on our monkeypox program. So Dr. Welbill.
Thank you. Thank you, Mr. Rocha, Chair and members and others on the call. So here we have our global outbreak. As you can see, over 360,000 cases globally, over 25,000 cases in the US, over 1,000 cases in Illinois, the majority of those being in Chicago, with 67 hospitalizations and a little bit over 100 cases here in our health system with 8 hospitalizations. Next slide, please. And I want to point out our vaccination program. So as of today, we've given over 2,000 total doses of vaccine the majority of those being first vaccine, but we are really, reaching out to everybody who's received a first vaccine to get their second vaccine. And most of these are being done at the core center. Now, prior until 2 days ago, we've had no data on efficacy of the Janios vaccine that we are currently using. And it's really great that CDC 2 days ago published some real world data on the vaccine. So what they found, first of all, they looked at 32 US jurisdictions from July 31st to September 3rd. And what they found was that the incidence of monkeypox among persons who were recommended to receive a vaccine was 14 times higher among those unvaccinated versus those that received a vaccine at least 14 days earlier. So this is really encouraging data that we're seeing. Again, this is real world data, so it's not, there are a lot of limitations. For example, we don't know what the behaviors of each of these persons were, nor do we know what their comorbid illness is at this time. But CDC is committed, they say, to continue to update this sort of data. And this is exactly what we need since we haven't had this data before that. And that said, CDC has also expanded who should get the monkeypox vaccine. And just this morning, Chicago Department of Public Health released their new expanded vaccine recommendations. And I'm just going to read them to you since I just received them. So there's now anybody is eligible who's living in Illinois, who has had skin-to-skin or intimate contact with someone diagnosed with monkeypox, anyone living with HIV, anyone eligible for or currently taking pre-exposure prophylaxis to prevent them from getting HIV, anyone that exchanges goods or services for sex, and then of course that's in addition to those who were already eligible for getting a vaccine. Next slide, please. And so this is just, you can see the vaccines now that, especially that we understand that they do appear to be effective along with change in behavior. We are seeing decreasing cases in the US. And next slide. Also seeing decreased cases in Chicago. But that said, CDC did also recently put out a health alert describing severe manifestations of monkeypox disease. And as persons on this call may know, that there have been 3 deaths in the US that have been attributed to monkeypox. And in this health alert, what they described were these severe manifestations largely found in persons with advanced HIV who were severely immunocompromised. And they included things like requirement of amputation of a limb, likely due to severely necrotic lesions, probably secondary bacterial infections, but also bowel obstructions, bowel lesions, a lot of scarring, and other manifestations showing that the virus is really disseminates throughout our bodies, including encephalitis, so inflammation of the brain, myocarditis, inflammation of the heart, conjunctivitis, or corneal ulcers. So everybody who's diagnosed with monkeypox should have an HIV test as well as being tested for other sexually transmitted infections, and we certainly do practice that. We do have some, I will end this with some better news, so next slide. There was also a recent MMWR based on a study that Marshall et al. Did looking at the risk of acquisition of monkeypox disease to healthcare providers. So we know that there's approximately 8 healthcare providers worldwide who have had documented monkeypox, presumably due to healthcare worker exposure, and 1 in the US. This study that was done by Marshall et al. Looked at 313 Colorado healthcare providers. They were exposed to 55 patients. And what they found was that overall recommended PPE use and receipt of post-exposure prophylaxis with vaccine was very low. So only 23% were all of the recommended PPE, even though 28% had a higher intermediate risk of exposure. Of those, 12% received post-exposure prophylaxis. But given all of that, and after 21 days of monitoring, no healthcare providers acquired monkeypox disease. So we do know that the risk of acquisition in our healthcare system is very low. And that's all I have.
Wonderful. Thank you, Dr. Wellbell. Now we also have an update on the program, on our monkeypox update and community outreach and education program done in our suburban areas. So I'd like to recognize Dr. Lamar Hasbrook for the, who is the Chief Operating Officer for the Cook County Department of Public Health. Dr. Hasbrook.
Thank you, Mr. Rocha. So again, I'm not going to go over the specific numbers. They change. These numbers are changing by the day. So, but what I will stress in terms of suburban Cook, 120 cases that we've had in our jurisdiction. In terms of vaccinations, we've had from the state CDC strategic stockpile to the state and then to locals. We've had well over 2,300 doses or so of the vaccine. We've distributed or redistributed more than half of that. So we're meeting the need where we are. Next slide. So this table on the far right really shows kind of the epidemiology in this particular table by race and ethnicity. Of the 120 cases, you'll see that disproportionately Hispanics and Blacks are really disproportionately impacted. Their numbers are much higher than their numbers are in the population. So we've seen this pattern in Chicago as well. So the Latinx community and the African-American community is really at highest risk. So what that means is that we need to have specific targeting of both messaging and outreach for vaccination and prophylaxis for these populations, trying to match the need with the effort. Next, please. This is our epi curve, and it looks a lot like the national, the state, and Chicago's epi curve, in that we are kind of, the worst is behind us at this point in time. Obviously, it can be biphasic, it can go up again, but currently it looks like in suburban Cook, we're getting about 1, maybe 2 cases per day, up to 12, 13, 14 cases a week. And so we update this every week as a part of our dynamic website dedicated to monkeypox virus. Next. And then lastly, this slide just highlights a number of the things we've been doing to outreach, much like with COVID and COVID boosters and monkeypox. You know, the best weapon is really education, accurate, timely, credible education. And so we've done a lot in terms of creating a dynamic website, again, which is updated constantly. All of our materials, including social media materials, are bilingual and available. We've done a number of Facebook Lives, and we continue to make our messages out there and try to get them as consistent as possible, and work with an increasing tent of providers and other community members to get the word out. And I believe that might be it. Yes. So I'll hand it over to the next speaker. Thank you. Are there any questions?
Any questions for Dr. Hasbrook or for Dr. Wellbell? All right. We'll see no hands. Next, I have also brought forward the board under my report, substance use disorders and how we're addressing them with our organization is a top priority. It's a top priority in our community and a top priority for our system. And so I wanted to take a brief moment to recognize two outstanding leaders who are doing extraordinary work in helping to pioneer some innovative programs in substance use disorder management here at Cook County Health. And so here today, under the CEO report, I have asked Dr. Bill Trick, Director of the Collaborative Research Unit at Cook County Health, and Dr. Julie Nowinski, Contract Attending Physician for Behavioral Health under the Department of Family and Community Medicine and the Center for Health Equity and Innovation, to come before you and present the efforts and work that not only are being done here, but have been recognized nationally for the excellent work that is being done to combat substance use disorders. So Dr. Trick and Dr. Nowinski, if you want to please proceed.
Sure. As a brief introduction, Dr. Nowinski-Konchak graduated from our preventive medicine training program, and over the last several years, through successful grant acquisitions, has built, as Mr. Rocha said, a national model for substance use treatment. And she will speak to the program that she's built over the last several years.
Thank you, Dr. Trick, Mr. Rocha, Chair Taylor, and directors. Really delighted to be here today. And this work reflects the work of so many colleagues across so many departments at Cook County Health, and want to especially recognize Ms. Sarah Elder, Manager of Behavioral Health Integration, and Dr. Jeff Watts of Department of Psychiatry, and a very warm welcome to Ms. Pam Esposito in her new leadership role. In brief, back in 2017, in response to rising overdose rates, Mary Sadak and Dr. Loafman convened partners across the system to work together to increase access to evidence-based substance use disorder care within ACHN and across the system. Our approach was to embed services where patients are already coming for diabetes care, hypertension, and depression, and train teams to provide medications for addiction treatment and recovery support services. Our approach required that there be no wrong door, meaning any touch point we have in the system or with our partners should be a solid entree to coordinated substance use care. Our principles are listed on the left. In brief, multidisciplinary, team-based. We included a new team role, a recovery coach up here that you'll hear about. Patient-centered, the patient defines their recovery journey in their terms. Comprehensive outcomes, physical, mental, and social health and well-being. Abstinence is an important measure, but not our only measure. And to, of course, decrease risk of overdose and help patients make any positive change to reduce the harms of ongoing use. You'll see in the green figure that the medical home is at the center here. And that's where all of our care kind of points into. In January of 2018, we had 4 health centers, 11 providers, and a little over 200 patients online receiving care at the health centers. By the end of 2019, all health centers were online, and today we have over 500 active patients, at least 36 active medical providers, which is more than a tripling from 2018. Again, the intervention is access to the medications, motivational enhancement, recovery support, and linkages. For many patients, the team also includes social work, nursing, a growing number with care coordination, primary care, sometimes psychiatry, and of course, external partners whenever that's part of the patient's care plan. A few examples of the no wrong door, I'll just give 2 in brief. You see the Bridge Clinic on the top right. The Bridge Clinic is physically at the core center and is also a telehealth service line meant to be a low barrier, low threshold access to starting or restarting care. It was launched in 2018 and got a lift in 2021 with SAMHSA funding. As an example, we had a patient yesterday who finished residential treatment at Gateway and was able to come the same day to core and get started with us the day before we had a referral from Mount Sinai. And also very importantly, it's just a stable re-entry place when patients' journeys, take them off their path, they can come right back, they know we're there. Second example here is CIRMAC. I think you all know this, and Cook County should be really proud that CIRMAC is one of the first healthcare providers in a jail nationwide to provide all 3 forms of medication for opiate use disorder. In the first half of 2022, over 500 individuals were started or received medications in the jail. And there's a team of coaches and care coordinators who provide the critical post-release care coordination and linkage, serving last year over 500 pre-release engagements and over 300 connections upon release. Just last week, we heard from we heard an anecdote, a patient who was at one of our partner recovery homes, Henry Sober Living. Our coordinator, Jewel, was talking to a new patient working on their plan, and another patient grabbed the phone and said, "Jewel, don't you remember me? You helped me 6 months ago. When I was leaving the jail. I'm doing great. I'm in a methadone clinic. I'm working. I'm in groups," and it was great to hear. Next slide, please. And we know that to have the most impact, we have to look outside of the walls of Cook County Health and really break down those silos with partners and take what we call a regional learning health system approach. I'll give you just 2 examples here. We know, of course, the harms mass incarceration causes to our patients, and proud Cook County Health keeps advocating for policy change. We also know we can do more right now for the patients in the system. For example, we partner with the Sheriff's Office to increase access to medications and recovery support services for individuals leaving electronic monitoring, particularly with a housing insecure flag. This was launched in October 2021, and we've had 394 referrals, with nearly 40% being successfully linked to substance use or wraparound services. Later today, in an hour, actually, we're launching a intervention in the Cook County problem-solving courts in Judge Walsh's courtroom to create a peer as a resource for all of those that are in the drug court program. We also partner with community-based organizations. For example, the West Care Foundation of Illinois operates a street outreach that we fund through our Bridge grant. So they're on the street, meeting people, offering services, and linking to Cook County Health for anyone that wants to initiate care. We work with the state's Division of Substance Use Prevention and Recovery, and in February we launched a recovery home navigation service. We know from our patients that's just hard to navigate. There isn't that easy button, and we've had 51 referrals so far and are working on this approach with partners. Funding is on the right. It comes from an array of partners, federally and state and local. Next slide, please. On the right-hand side, this is really, I think, the secret sauce and the glue to the program. This is Eric Beatty, one of our recovery coaches, one of our peers. We have peers across the system in ACHN, ED, Bridge, and jail. And, Eric was being recognized for addiction treatment professionals day. And what the peers do is, many of them are in recovery themselves, high touch, accessible, breaking down barriers, getting those IDs, breaking down transportation, direct support. And we're seeing it's working. On the left-hand side, you can see 2 quotes from patients. These were collected around 2018, and I think speak to the power of this intervention. And next slide, please. And in closing, want to share this visual with you. Last week, September is Recovery Month, and we celebrated at Cook County Health by bringing together partners and leaders from across the system to reflect on what recovery coaches are. And I just encourage you to read a couple of these quotes. These are direct quotes from the teams working with the coaches or the leaders that support them, and you can see the power of this role. 5 years ago, when we were trying to spread this, we were selling the program, trying to ask clinics to embed a coach and start to offer this service line. Now the tables have turned, and the coaches are an indispensable team member. So, we hope as we move into 2023 that we'll move towards a fully staffed model and really be able to see our full potential, expand our offerings, reignite proven implementation strategies, analyze our data further, and inform quality improvement, and work with partners to continue to strengthen this regional learning health system approach. Thank you so much.
Thank you very much. Any questions for our team? All right. Well, then hearing none, I will go quickly with just a few system-wide operational updates for the team. A few updates that we had was that we had a hiring fair for medical assistants that resulted in 17 accepted offers, 6 in primary care and 9 in specialty care. As you heard, we went live with our monkeypox vaccine at additional sites in mid-August. Now offer monkeypox vaccine at 4 ACHN community health centers, including 4, Arlington Heights, North Riverside, and Blue Island. The total vaccine dose administered so far is 2,033. Patients and community members can now make appointments for monkeypox vaccinations and learn more about testing, treatment, and triage through that process at monkeypox.cookcountyhealth.org. If you have not been to it, I encourage you to go. It's a great innovation and tool that was created to assist to know what treatment and how you can pursue your treatment course going forward. We also launched the Cook County HIV integrated program with the Cook County Health Infection Prevention Warm Line phone number for linkage to non-emergent sexual health services. The warm line is staffed by the Cook County Health Infection Prevention team that is staffed Monday through Sunday, providing an avenue for clients and community members to obtain HIV and STI testing, treatment, and PrEP and PEP services. We want to thank our team for bringing that forward as a new opportunity for our community. Also in January 2022, ACHN was at 46% breast cancer screening rates, targeting 65.7 as their goal. As of August 1st, 2022, the team improved to 54%. They completed 3,000 additional breast cancer screenings from January 2022 to August 2022, as they did for the same time frame the previous year. Providence Hospital continues to prepare for the resumption of ambulance runs. In August, Providence performed 321 surgical cases, the most in a single month and over the 5-year tracking system that we have had. So it was an all-time high in over 5 years, and we even come back and look a little further. It's been an all-time high that we have seen in a single month in quite a while. So congratulations to both our Department of Surgery and the Providence team for helping to bring back increased access at Providence Hospital. The Cook County Health Foundation will hold its annual gala, The Future is Bright, Moving Towards Equity and Excellence, on October 12th at the Hyatt Regency in Chicago. For more information, please visit www.cchealthfoundation.org. Again, that's cchealthfoundation.org. Also remind everyone that Medicaid open enrollment is there. We have a new campaign that says there's a plan for that for 2022 and 2023. As Medicaid opens, we will be working with our County Care program. County Care is planning for an upcoming choice period with its new campaign entitled There is a Plan for That. The campaign will run from October 2022 through May 2023 and highlight County Care's extensive benefits and network. The campaign will include out-of-home, digital, and broadcast advertising. And that is the conclusion of what I will be presenting today, and submit my full report to the Board of Directors. Open for any questions that the board may have.
Director, do we have any questions? Thank you. We appreciate the thorough report, Israel, and for all those who presented under your time. It was quite helpful and informative, and one like to thank the staff, on behalf of the board, for all the work you're doing during these trying times, and the teams, both the staff and the medical teams. We really appreciate it. As I believe the board does not have any items for a closed discussion today. So if there are no other questions or items to discuss, I believe a motion to adjourn is in order. Do I have a motion?
So moved.
Second.
Thank you. The motion has been made and seconded. Madam Secretary, please take the roll call.
Chair, I don't believe we need a roll call vote for this. I think you can just take a voice vote on the motion to adjourn.
I'm sorry?
Voice vote.
Voice vote. Okay. Voice vote.
Sorry.
Voice vote. Is that what we're saying?
You take a voice vote.
All right. Motion is made. Can we have a vote? All in favor?
Aye.
Aye.
Any opposed? Thank you. The ayes have it. Motion carries. The meeting is adjourned. Thank you all. Have a great weekend.